Good morning, everyone. It is a great honor for me to stand before you today and welcome you all to the celebration of 75th anniversary of the World Health Organization on this World Health Day. Our theme for today is 75th years of improving public health, health for all. Organized by Delhi chapter of Indian Association of Preventive and Social Medicine, Delhi chapter of Indian Public Health Association, and Center for Community Medicine, AIIMS, New Delhi. The program is also supported by IPHA AIIMS branch and NCEAR-A. This is a timely reminder for our collective commitment to ensure that everyone, everywhere has access to healthcare need to live a healthy and fulfilling life. By its very word, health for all is an oxymoron, because if it is not for all, it cannot be for an individual, and that is the basic premises for this concept. In terms of communicable disease, we understand that there's a risk for getting the disease from other people, but now increasingly non-communicable diseases also. Behaviors are something that you can imbibe from other person. So if one person is healthy in a room, the other person will automatically be healthy. And by healthy, I mean the North Indian connotation of healthy. That is, if you are not overweight, that you are not healthy. So these are also learned behaviors that we imbibe from each other. I want to extend a heartfelt thank to all of you in the audience who have joined here today. The brief background: on 7th April 2023, the World Health Day, organization will observe its 75th birthday, and since it is a Good Friday, so we are hosting it today on Wednesday. Since its inception in 1948, the World Health Organization has played a critical role in shaping global health policy, setting standards and spearheading efforts to improve the health and well-being of people across the globe. As we reflect on the accomplishments of the past 75 years, we must also acknowledge the challenges and opportunities that lie ahead of us in our quest for health equity. The concept of health for all has been popularized since the 1970s from the AIIMS Declaration. Health for all is a call to reclaim the right to health as a fundamental human right, and it's very topical this in current week because there was a massive movement in one of the states in North India regarding right to health movement. So this has been a very topical subject, but it's even more relevant in current scenario. It is also a call to reaffirm the commitment to primary health care. Health for all means that health has to be brought within the reach of everyone. It is basis for World Health Organization's primary healthcare strategy to promote health, human dignity, and enhance quality of life. Today, we are fortunate to have renowned experts who will be sharing their knowledge and insight with us. I want to take a moment to thank Professor M. Srinivas, Director of AIIMS, our Chairperson, Padma Shri Professor Chandrakant Pandav, distinguished guest, Professor Lalit Mohan Nath, who is a former Director and Dean of AIIMS. Thank you, sir, for gracing this occasion. I welcome our speakers, Dr. Sanjeev Kumar, former Executive Director, National Health Systems Resource Center, Dr. Abhay Shukla, who is a Senior Program Coordinator at Sathi Sehat. And most of the distinguished speakers and chairpersons on the panel are alumni of this institution name, so it becomes even more special occasion for us. Once I again welcome you all to this session and enjoy the enlightening discourse. I'll end my introduction with a brief comment from Rudolf Virchow, a very famous German doctor, and there are multiple ways to describe it. I'll stop at that. So he said, the physicians are the natural attorneys of the poor, and social problems fall to a large extent within their jurisdiction. So we have to understand the larger context of health for all, the political dynamics of it, the social dynamic of it, the economic dynamics of it. With this, I'll request Professor Sanjay K. Rai, who is a professor at Center for Community Medicine, is also the president of Indian Public Health Association, to deliver the welcome address. Thank you.
Kapil, with your permission, I want to say just one line about Professor Sanjay Rai. He has saved the lives of millions of children in India for not advocating vaccine in children. Millions of lives. So they should be grateful to him for not getting.
Thank you, sir.
And second thing is, All India Institute has a history that they speak what is science, not what is otherwise called politics. So he has been speaking science, especially in COVID-19. Thank you, Dr. Kapil. Thank you.
Thank you, sir. Thank you very much, and thank you, Dr. Kapil. Namaskar, all the dignitaries on the dais, dignitaries of the dais, members of and executive members of IAPSM, IPHA, and Delhi chapter, AIIMS chapter, resident, other staff, research staff, and my faculty members, ladies and gentlemen. Really, it's a great honor for me to share this special occasion with all of you. We all are here to celebrate the 75th year of improving public health, health for all. This is the slogan given by WHO for this year, World Health Day. First of all, I would like to thank our director, Professor M. Srinivas, Dr. Ellen Nath, ex-director, Dean, AIIMS, New Delhi. He was head of department, also Center for Community Medicine. Professor C.S. Pando, former head of department, Center for Community Medicine. Both my keynote speaker, Dr. Sanjeev Kumar, is ex-executive director of NCEAR-A, Dr. Avasula. Dr. Avasula does not require any introduction. We all know he is the real practitioner of community medicine. So he practiced community medicine in the community. Dr. Jugal Kishore, President of Delhi IPHA chapter, Dr. Anil, representative of IAPSM Delhi chapter, and all others. The theme of this year is for World Health Day celebration is your health for all. Health for all is not a new concept. Since almost more than 45 years, when first time this concept was propagated by WHO in 1978, we know this Alma-Ata Declaration 1978. Since then, and the target was to achieve health for all by 2000 AD. So we almost 45 years have lapsed, but we have not achieved this. Although in modern era, this concept is 45 years old, but if you recall our Quran, there is a many PPSC that we have one phrase, Sarve Bhavantu Sukhina, Sarve Santu Niramaya, Sarve Bhadrani Pasyantu Ma Kasid Dukh Bhagavad. Even in that phrase, कि सभी लोग रोग मुक्त रहें, सभी लोग खुशी रहें. So it's health for all, our universal health coverage, all are same, that everybody should be happy and without any disease. So all this concept was already there in the Indian culture, I can say. Our both the speakers, Dr. Avasula and Dr. Sanjeev Kumar, they have very vast experience in others public health, primary health care, also in health for all, universal health coverage. So they have worked in the real field. So there is no need to unnecessarily introduce this topic. They are the experts. So once again, I welcome you all in this World Health Day celebration. And thank you very much. Thank you, sir.
Thank you so much, Professor Sanjay. Now I'll request Professor M. Srinivas, Director AIIMS, to give the inaugural address on this occasion. Professor M. Srinivas is an administrator par excellence and has played transformative role in strengthening medical colleges and hospitals run by ASC Corporation. So let me complete, sir. In AIIMS also.
Thank you. I'll only take few words. First of all, our pranams to the people, our respected teachers, Professor Nath and Professor Pandav. And it's always great to be amongst the community medicine people. You know, as a child, we used to listen to that Alma-Ata Declaration. And then our community medicine. One of the finest books which we have read in medicine is probably Park and Park. You know, very few of them were Indians. You know, maybe microbiology, Anantanarayan, parasitology, Chatterjee, and community medicine. Other than that, I think we never had that occasion to read any of the Indian editors and the books. You know, and then it used to be always a dream. You know, in 1980s when we joined MBBS, then Health for All by 2000 AD is the slogan, and it used to be the thing. And off late, when we completed community medicine, that slogan was deleted from the community medicine books, I think. Then nobody talked about health for all. It's good that on this day, on this occasion of 75th anniversary of the WHO, we are here again, coming back to the commitment of health for all. This is something which is very nice. And you know that the AIIMS community medicine has always been in the leadership, be it from the policy and advocacy of the country and also to the international arena and the WHO. In fact, Dr. Pandav, Professor Nath will be the testimony to that, as you enter the WHO thing, then the dancing Nataraj, which is there, that gives the vibrations and the things to the WHO also, that, that is something which is very important, that we have been part and parcel of not only the country's policy and advocacy, but also for the international organizations, including WHO. And it's again, it's a time to say thank you to the people, congratulate you, and then welcome the people from other than the institution who are here, and so that we have a healthy interaction today, and then keep forward, so that we continue to be our services from the department to the country and to the WHO and the world, so that the real thing what we want to achieve, health for all, is achieved through these experts which are sitting over here. And looking forward that, sir, with your blessings, with the people who are here, the one amongst us, all from the department here, the community medicine, goes to the highest levels of the WHO and then carry forward. We have gone to the levels, but we haven't reached the highest of the level. I think we look forward for the blessings of the people, so that the Department of Community Medicine will take the people to that highest of the standards, and then we be there as a leader, not only for the country, but also for the world. Thank you very much.
Thank you so much for very encouraging words. I now request Professor Jugal Kishore sir, who's representing the IPHA Delhi chapter, to give the opening remarks.
Very good morning. It's my proud day just because of I'm speaking in front of my teachers, Dr. L.M. Nath. I remember the first day when he interacted with me. He said, "Kab chhod rahe ho?" अभी भी याद है, मैं सबको बोलता हूँ कि actually but then he said that अच्छा, what are your choice? I said पहली choice मेरी psychiatry थी, दूसरी community medicine. तो कह रहे ठीक है. तो अभी तक याद है और सर हमने छोड़ा नहीं. एंड उसी में फिर थीसिस मैंने साइकेट्री में की और अभी तक मेंटल हेल्थ इज द मेन एरिया. डॉक्टर Srinivas is there, sir. With your permission, I just from our IPHA Delhi branch, just want to highlight some of the things as Dr. C.S. Pandav has said, that we have to be evidence-based, and my all this statement is going to be through my book, The History of Public Health. And just want to say that every Indian is entitled for high quality healthcare, is irrespective of the constraint that emerge from society, economy and politics. National and international forces that play crucial role in the accessibility of the quality medical and healthcare. But definitely the class, caste, region, religion and socio-economic status, external economic forces, ideology, they are all determining our healthcare services. And I always teach the multifactorial causation in a broader manner. We know that British are the one who has brought this state-run health services. We have one evidence from the Ashoka time, and we can say it was a state affair. But after that, it was not. And we had lost somewhere the public health. After independence, India accepted the idea of welfare state, and that provides a comprehensive health services to its citizen. Since independence, various committees, we all know, various commissions has appointed for health issues, and they have deliberated on things. But, the healthcare is given to state and also to center to legislate and frame policies according to the requirement of the region. The government has also opened the sector for private institutions to provide their services and compete with the public funded program and policy. That was initially the aim. But today, we all know that how it is all shifted towards one-sided. Numerous health legislations, policies, and health plans and various networks has been established. Definitely, as a result of this, the health services, has reached to a very good level, and we can say that infant and maternal mortality rate has declined. Our life expectancy has jumped, to 70 now, and we have large number of medical institutions and health workers and all such. Improvement is definitely, showing some picture which is appeared to be very good. But we all know that it is not uniform and not satisfactory. Rather, large chunk of our population is still deprived of our, health services. Now, the disparity of this health services are actually, you can see there are some developed areas, there are upper class which have huge access to all kinds of. Then on other side, we have a remote area and marginalized section of society where, you will not find that kind of health services which we are, hope or maybe I think aimed. So what we can say is somewhere we have failed to deliver the preventive and curative services, mainly through our, as Dr. Srinivas has said that actually we have read the park and park, but sir, I'll tell you that in our whole 3 years of training in our Center of Community Medicine, we have never read park. And I still teach my student that, actually we have to go beyond park and we have to, be more into the real picture of what is going on. Yes. But issue is that, if we compare these all indicators, then we have learned that just showing the pre and post in one group is not going to give you any satisfaction, or maybe I think you cannot say we have achieved a lot. We have to compare with the countries. The comparative group should also always be there. And then we realize that our indicators, whether it is a life expectancy or communicable disease indicators or non-communicable disease, when we compare with the Sri Lanka, China, Bangladesh, I think some of the indicator in malnutrition is worse than even Africa. So what kind of achievement we are talking about? So we have the commercialization going up, and we have over professionalization which is there now, which has increased the cost of healthcare, reduced autonomy of individual. Now because of that, again the picture of health is now divided into class and caste, religion and gender. Scheduled caste, scheduled tribes subgroup, you can always see that it has no access to private health services, and because of that, they are always dependent on the public health sector. So this is very unfortunate that after 6 decades of independence, our people have failed to get the essential healthcare services. And this is actually a time when we say that primary healthcare and health for all, because the resource allocation is same as of 60 years, we are still finding that it's not even reached to 2% of our GDP. Some of the things which has been said of the low ratio of the doctors and patients and infrastructures, when we look at the board committee report and National Health Policy 2017, which is the most recent, you will find no difference when we talk about the health of the people. Although you can always say that in number, definitely our population has also increased, so you can't say that we have achieved a great thing. So health for all is still a distant dream for us. The growth rate which we have seen as the number of primary health centers, the number of sub-centers, you will find that actually initially the 5-year plans, the first, second, third and fourth, you will find the number is increased tremendously. But last, plan, the 12th and 11th plan, the number has not increased. And till today, those numbers are still staggering. And, so the growth of the infrastructure is still very poor in most of the places. So somewhere you can say, I think the policy maker, which they say that they are making the great policy, somewhere we have failed. And the implementers, particularly the ruler of the country, has failed totally to prioritize the health. And that is what I want to say, that when we say health for all, somewhere we have to see that where we are developing, where we are going. I just take one indicator, that how much serious are policy makers and our governments is when we are not able to increase our GDP more than 2% in 6 decades. So somewhere I can say the bureaucrats assist the ruling class and the policy maker by implementing their policies. This has resulted in a small section of population consuming and controlling 80 to 85% of the total income and resources without producing any significant improvement in health. We already know the curative services have not given any health. We already know that 2 to 3% of the total health is delivered by curative service. Still we pour a lot of money into curative services. The preventive is nowhere there. So the poor are peasants and rural class and our working class. Even our occupational health, just see that 99 or 90% of our working is unorganized sectors still do not have the occupational health services. So the access is totally, I can't say that satisfactory. So we have to have a different types of system for policy, planning and politics and implementation for health for all, including this, when we say all, should have the common person. Not that all means only the limited group. So with these remarks, I congratulate Kapil that he has, gathered all the associations, and we are hoping that Delhi should lead at least in, policy and also advocating health for all. Thank you very much.
Thank you so much, sir, for portraying a very candid and honest picture of the reality that we have today in front of us. But at the same time, I think India has a unique position in having the largest trained health workforce available. So there is no reason that we should have such dismal statistics that we portray. In fact, there's an interesting statistics that per 1,000 Americans have more Indian doctors than per 1,000 Indians have an Indian doctor. So we are exporting our. So that is, I think, we have to make a change. And again, Rudolph Virtue had said that medicine is nothing but a politics on a larger scale. So if we don't intervene and change these semantics, there's a limited point in talking about them in the longer run. Now I request Dr. Amod Borle, Assistant Professor from Maulana Azad Medical College. He is representing the Indian Association of Preventive and Social Medicine's Delhi chapter. Thank you.
Thank you, Dr. Kapil. I am talking on behalf of the IAPSM Delhi chapter. I am Dr. Amod, Associate Professor at the Maulana Azad Medical College, Community Medicine. So I welcome all the dignitaries here and all the participants who are here for the celebration of this World Health Day. As discussed earlier, this theme is the for World Health Day. This year is the health for all, everyone, everywhere. We are aware that we are talking about this since 70s almost. And as earlier Dr. Sanjay has also said that we are still to achieve it, and Dr. Jugal sir has kept the complete picture. What are our achievements and where we are lagging and what are the areas of the concern. So probably this is the reason the theme was chosen, the health of all, on this particular day when it's the 75th anniversary of the WHO, to look back into the past, to look back into the public health successes, challenges and opportunities we have in the present that we can take the public health ahead. So World Health Day celebration, this provides us the opportunities for creating the awareness. It also provides us opportunity to draw the attention towards the issues which are of the public health concern for the communities, not only the nationwide but worldwide, and when we can relate with the worldwide statistics with ourselves. So probably this is the helpful for creating the awareness as well as the advocacy also, the platform for the advocacy also. So many of the programs are organized for the celebration of these days, and we have the stalwarts and dignitaries as we are sitting here who actually worked for the policy as well as said as right, sir has rightly said that they have worked community medicine into the community. So no better perspective can come out apart from these discussions with these keynote speakers, and we can take these messages from them so that we can make it into the practice and we can have improvement in the healthcare. Recently, sir has also pointed out some of the lacunae are there. COVID pandemic was also there. We get certain lacunae, inequalities, which expose inequalities also for healthcare access, maybe the outcome related, but also showed some positive things like working in the multiple sectors, how to coordinate with them, the participation at the community level. So these are some of the positive learning lessons, some of the concerns which are exposed, so we can sum up with this and we can take it to the forward. So I welcome again all the dignitaries here, and no better than these keynote speakers will be here who are having the ground as well as the policy making experiences, and definitely the guidance will be there. So I congratulate and give my sincere thanks to the Center for Community Medicine, Dr. Kapil, IPHA France, along with IPHA Delhi and IAPSM for organizing this events. Thank you very much.
Now we come to the main course of today's program. We have Dr. Captain Sanjeev Kumar with us, and sir is an alumni of this institution, and if I'm correct, he's from 1971 previous batch. And we are fortunate that we have two of his batchmates, Dr. Pandav and Dr. Yash Gupta, also in the audience. So he has a long legacy. And after serving extensively in various positions in UNICEF at global level, several years of that in Africa and Geneva, sir decided to super innovate in our neighborhood. So we are lucky, and that is why we could get him here without any resource implication. He could just walk over from his home to this hall to give a lecture. So we are grateful to your presence. And sir's latest passion is on public health leadership. So he has been giving lectures pro bono across India and training young public health personnels in leadership. So he has more than 1,000 alumni students currently in India. Thank you so much for today's lecture.
Thank you so much. Coming to this room and to the institute is always nostalgic. I remember our first day, Yash and Chandrakant will remember. This is the room where Dr. Ramalinga Swami, the then director, welcomed us to the institute on our first day. We had a cup of tea with Dr. Ramalinga Swami and other faculty members. And it reminds me of this great man. He was a special advisor to James Grant, and he was visiting India. And I met him in the corridor, and he remembered me. He said, "What are you doing here?" I said, "Sir, I am working here." And he went to the chief of operations office. He said, "I don't want to take office car." He had a big car lined up with UN written on it. He said, "No, I want to go with Sanjeev." So I went to his house. And he gave me a cup of tea. His wife gave me some snacks, and he used to live in Horsekhas, and I was living in Horsekhas DDA flats. So you know that great man. I had a small car, Maruti Swift थी मेरे पास. उनको तो बहुत बड़ी गाड़ी मिली हुई थी. He declined that. You know, this is the caliber of the leaders we have seen. And then Dr. Lalit Nath, I have told you a little bit about my interaction with him, but I want to share another interaction with him. For my MD thesis, I went to him, "Sir, MD thesis आपके साथ करना है." I was posted in urban area. No? You had those days politics in the department, urban area में तो urban वालों के साथ ही काम करना है. He said, "Sanjeev, you understand implications?" I said, "Yes, sir, I understand implications, but I want to work with you." He told me, "Go to the library, make a list of the topics you are interested in, Imagine the first list of topics was 15 possible topics. He said, read more about these topics and come back with a shorter list. I came back with 3 topics. And then, it took me about 1 week or 10 days of this exercise. He said, now tell me which of these topics is closest to your heart. And it was infant and young feeding in early 80s. That was drawing a lot of attention. 1984, all of you remember, first infant young child feeding guidelines came from World Health Organization. This was before those guidelines came. And when I went for my interview in UNICEF, sir, I just mentioned, they asked me how immunization and breastfeeding are related. So I started explaining. The person who was heading the interview panel asked me, I've read all your articles. That was his wisdom, how he got me to the topic which was most relevant. I have heard a few negative sides about health progress in India, and I am an optimist. When I was born, 3 of us same age group, close to 70, life expectancy in early 50s was 32 years. And if the life expectancy had not increased, you would have read my obituary in 1985 immediately after doing my MD. And I am close to 70 and standing in front of you and still full of enthusiasm. Some good things have happened in health. You look at infant mortality rate, child mortality rate, maternal mortality ratio, good things have happened. Yes, we need to do a lot more. So look at the positive sides and how you can address what are the challenges. So with this, I will be asking a few questions. Only residents are eligible to answer, and those who give the correct answer will get something from me. Can you correct answer?
Residents or who have residents?
No. Then that will include Dr. Nath also. We don't want to have that current resident. What is this building? Any more guesses? हम health for all की बात कर रहे हैं, उससे कुछ related. That is my hint to you. Health for all की बात कर रहे हैं. I've been to this building on 25th anniversary celebration of an event. अभी तो बता दो. All right, I'll take this prize back if you do not answer. All right. This is the building where Alma-Ata Declaration was written. This is the building where the world leaders got together in Alma-Ata. That city is now called Almaty, and I went there as UNICEF delegate to the celebration of 25 years, Panda.
I also spent there to Almaty when I went to Kazakhstan as a UNICEF consultant. Remember the year, but I've seen Almaty.
The town is called Almaty today. It used to be Alma-Ata when it was part of USSR, and then USSR split into 15 countries. That's history. I won't go into detail. I've been the regional advisor for those countries. I've spent 5 years working there. So one prize goes back to my pocket. Let's look at next few questions later. I will, when Kapil asked me to prepare for this talk, I was at a loss. What do I speak? Health for all, UHC. Then I decided I will not talk of health for all, I will not talk of UHC. I will talk of my experience. The topic he smartly gave me was from Alma-Ata to New York to field realities. Abhay will talk more about field realities because he is working in the field. But those of you who are doing residence here, please give your 100% to your rural posting. That will stand with you throughout your career. The strength I had when I worked for UN, the strength I have today is because of the work I did at Primary Health Center and in Ballabgarh Hospital. So give your 100% to that. That will not the lectures taken by your faculty, not the books read by you, but how you understand the community, how health works in the community. So I'll be focusing on that. How UN agenda has evolved from fragmented to comprehensive, briefly about Alma-Ata Declaration, Millennium Development Goals and Sustainable Development Goals, approaches in setting up the agenda. Who decides what is the agenda? Then briefly, 1 or 2 slides on health for all and UHC. Is it new? Global agenda set by member countries is good, but how it is implemented at the grassroots level, that's how this topic is realities. Are we clear what is health? Health appeared only in 1948. Before that, there was no health. There was a great wisdom in various civilizations. When Europeans were living in caves, we had a great civilization in India. Didn't we understand health? So it didn't start in 1948. Health is much older. We need to dig deeper into it. Bring family in the center. We will look at one slide talking about it. Need to address the determinants of health for sustainable development. This is how the agenda evolved. 1960s, first UN development decade. Called for accelerated measures to eliminate illiteracy, hunger and disease. 70s, second decade, and 80s, 90s. If you look at the history of the UN, each agency was working in its own silos. If it was environment, till Rio, it was UNEP, UN Environment Program, who was leading, not the UN. Others said, not my agenda. If it was related to children, UNICEF. It was related to health, WHO, World Health Assembly will decide. Come 2000s, for the first time we had a Millennium Declaration. And in the Millennium Declaration, they came up with agenda which was cutting across all the UN agencies. And then came Sustainable Development Goals, which were even more comprehensive. What was the approach in the past? You call all the member states. If I remember correctly, Dr. Nath was involved in heading the initiative of Health for All in India. The then Minister Shankaranand gave him that. So he chaired many meetings on that. So the countries were consulted. But in name of people participation, civil society participation, almost nil. A typical UN meeting like we have IAPSM and IPHA meeting, you want to come up with a declaration, a draft is circulated on day 1 and it is adopted on day 2 with some minor changes. That is how typical declarations came and announcements came from the UN. Millennium Development Goals, they declared the Millennium Declaration and then somebody said, how will you measure or how are we going on Millennium Declaration? Some of the experts sitting in UN headquarters got together and I have been to that room in the basement of the UN and they spent one day writing what will be the Millennium Development. And when they were coming out, somebody asked them, where is environment? Oh yes, we forgot environment. They came back to that basement room and wrote about environment. That is how goals were decided. But in Sustainable Development Goals, 6 years before the goals were adopted, consultation started. Started where? We the people, the public of the whole world, they decided. They had large-scale consultation. They had 2 million people face-to-face consultation, household surveys, and around 5 million people gave inputs online. And then this agenda came, and if you read the agenda, it is more or less same what came out as Millennium Declaration. 2010, the consultation started with engagement of the public. And then the experts got together, country heads got together. Earlier, if there was a health-related agenda, it was World Health Assembly represented by ministers from the countries who came there, but this declaration was by heads of the state. They all came together. And briefly about what is health for all and what is universal health coverage. Health for all, health within reach of everyone in a given country through primary health care. Primary health care, not just the primary health care institution with linkages to secondary and tertiary level care. That is how it is. We don't need to say it's only primary health care and we will focus on that. It is the objective of economic development, removal of obstacles to health. like malnutrition, ignorance, unsafe water, unhygienic living conditions, deficiencies in medical system, and so on. Multi-sectoral approach. And what WHO now called is health in all policies, not just health policy. Every policy you have in every sector should have health. And we'll come to it later. Community involvement. I don't like this term. I will prefer to use community empowerment. What is UHC? Everyone everywhere has access to health services they need without financial hardships, including health promotion, prevention and treatment. Progressively expanding package of services, and we know today private sector is a main player because most of the services are provided by private sector except primary health care. Primary health care is still the responsibility of public sector. What is health? Do we understand what is health? I was very happy when I listened to Sanjay in the morning. He talked about Sarve Santu Niramaya. But let's go back. We have a civilization which the Westerners think is 5,000 plus years old. How was health described in Atharvaveda? And we have a Sanskrit scholar, Dr. Yash Gupta has done extensive review of ancient Sanskrit scriptures in India, has come up with a scientific publication on science in Sanskrit scriptures, and he knows Sanskrit better than I do. I will request him to tell us the meaning of what this means. Over to you. Yes, you want to come here? Yeah, please.
From there you can speak.
Thank you. Yeah. And those of you interested in this book can read about it. It talks about Vimana, how it was structured, how it was. It talks about Sushruta surgery, the rhinoplasty surgery he did thousands of years before plastic surgery was born in the West, and how that technique went to Europe through various parts of the world. Please. Thank you.
Thank you, Dr. Sanjay Kumar, for giving me this honor to say something in a very august gathering of highly expert people. Being from AIIMS, I always, my phone is, sorry.
It always rings at the
Yeah, it's wrong time. Yeah. I'll put it on silent. So thank you very much. Before I translate this, I just want to say a few things. I'll take only 2 or 3 minutes. First of all, I did my MBBS from here, and then I went to England. At that time, we all wanted to be surgeons, physicians, pediatricians, and I must say the community medicine was not on the priority list at that time. But I think I'm very pleased to see that gradually it has gained so much traction, and this has really transformed health services in India. Individual contribution to surgery and other fields are admired, but to be admired is how people have changed the actual, what we call the universal health care. And it has not been easy. Even in England, in 1948, the services were very fragmented. And there was a chap called Andrew Bevan who actually put together the primary health care and the tertiary health care and the interrelationship, something like which Professor Nath did, the primary health centers. I think the concept should have been taken a lot more forward than what it has done even today. And I think there's a lot of juice because the mainstay of health services is the GP, the general practitioner in UK, and which what we call the primary health care. So I think a lot more work can be done in that direction. And talking about this shloka, Pashyem Sharda Shatam, Jivem Sharda Shatam, Buddhem Sharda Shatam, Rohem Sharda Shatam, Pushem Sharda Shatam, Bhavem Sharda Shatam, Bhuyem Sharda Shatam, Bhuyasi Sharda Shatam. Sharad is the autumn. So here the Sharda is with a year because it comes yearly. And Shatam means for 100 years.
So this is, we should Pashim, we should see it with our eyes for 100 years. We should live, Jivem Shardashiram, we should live for 100 years. So those were the goals. Buddhim, that means our buddhi, intellect should be intact for 100 years, and so on and so forth. And so this is vital, that what Dr. Sanjeev Kumar is saying, that these concepts have been there for thousands of years. We just need to implement them. Thank you.
Thank you so much, Dr. Yashpal Gupta. Yeah, please.
This is 5,000 years. 5 plus 2, 7,000.
So the focus in ancient Indian wisdom was on longevity and the quality of life. WHO definition, yes, it is there. It says not merely absence of disease and infirmity, but when you go for medical checkup, when you look at only disease and infirmity. You don't look at how many people are healthy, their quality of life. So when the definition is put on paper in Geneva, or that it came into existence in California, San Francisco is where the meetings took place and WHO came into existence. Pandey, want to say that?
San Francisco, 1948.
1948. That is where WHO came into existence, not in Geneva. They established the office there. Thanks, Pandav, for that information. So you have to look at quality of life. That is what is health as per in ancient Indian scriptures. Is UHC health for all new? It goes more than 100 years. There have been efforts. And this is documented history. Undocumented history will probably go into the thousands of years. So you can look at, there have been efforts across the world to provide universal health care or health for all. Similarly, is it new in India? The concept was there in 1947, in the 1946 when Bohr committee report came, and it has been there throughout. First national health policy, I remember Dr. Nath invited Dr. Harcharan Singh, who was the first advisor, if I remember correctly, sir, in Planning Commission on Health. And he is the one who drafted the national health policy. And he came to our department, Dr. Nath invited him, and spent 3 hours with the residents explaining what all is getting into the first national health policy. And we were very fortunate. We heard it from the horse's mouth, what is being done to take the agenda from Alma Ata into practice. And then you have various other milestones which focused on it.
Nath's batchmate, Dr. Prema Wali, Dr. Ladit Nath, Dr. Harcharan Singh, they are from the first batch of MD in AIIMS, MD community medicine. So the 4th person, I think.
Right.
So,
So health for all.
And you are a member of planning commission.
Yes. Health for all is the history of Center for Community Medicine. So you have various stalwarts, Dr. Nath chairing the group which worked on health for all, Dr. Harcharan Singh writing the first national health policy and subsequent document. And many of us have been part of the National Health Policy 2017 was written when I was heading NHSRC as Executive Director. Dr. Abhay Shukla was involved. The chapter on medical education was written by Vinod Paul. So many stalwarts from this institution, including community medicine, have been part of it. Yes, please. Yeah.
In 2005, National Rural Health Mission, there were 8 committees, and I was a member of 4 committees. On reforms in medical education, public-private partnership, urban health mission, and Indian public health standards. Reforms in medical education के chairman पे there's former secretary head, Muslim gentleman, Javed Chaudhary, and the secretary was JSPD, Bhavani Chakra. She called me on a Saturday afternoon. Pandav मिलके report लिखेंगे. I said all India Institute of Medical Sciences were very proud of obedient students, but not obedient report. report take sugar. It's available on the net. Reforms in medical education.
Thank you, Dr. Panda, for giving us more insight. And all of you, I will not go into detail how Pradhan Mantri Jan Arogya Yojana, Ayushman Bharat has been looking at health. Health and Wellness Centers and National Health Protection Scheme, which is known as Pradhan Mantri Jan Arogya Yojana. Unfortunately, even today it is fragmented. You know, when they appointed the National Health created National Health Agency and invited Indu Bhushan to chair that committee. He was in the bank, Asian Development Bank, and I knew him from his days in Rajasthan. He was a bureaucrat there. I asked him, why don't you take Health and Wellness Center? No, that's not my area. So even today it is fragmented. Ministry looks after Health and Wellness Center, and National Health Agency looks after, now it is called National Health Authority. They look after the second part, and the focus is on curative care. Primary health care has not received as much attention. Health and wellness centers have been coming up, but it has not received as much attention. You all know the list of the point B, 6 services have been added to make it more comprehensive. Otherwise, we were focusing on maternal child health, family planning, and communicable diseases. We had ignored many other areas which have been included now. We need whole of population approach. Those who are healthy, they probably need more attention so that they always remain healthy. And they have desirable practice. Those who have risk factors, they need more attention because they are more likely to get the disease. Then you have you have population with disease who are not known, then you can do screening, pick them up early, and prevention continues here, and prevention continues with those who have disease. If somebody is diabetic, he should not get retinopathy, he should not get nephropathy, he should not get neuropathy and gangrene of his limb. It continues. It is not that preventive medicine stops when you have a disease. You have to continue working there. Health promotion must be continued. So that concept we need to understand ourselves so that whenever we are there on the policy making table, we emphasize this. Preventive medicine is very important and vital for keeping a population healthy.
Sanjeev, can you go back to the earlier slide?
Yes.
Actually, this is an excellent slide, but what is missing here, if I may say, is the allocation of resources for these 4 pillars. I have a question on this one.
Yeah.
I think that will be very vital to
Yes.
get to the people. I think the community services will take the most allocation. That will be very vital.
Yeah, and most resources, thanks Panda for saying, most resources should go to keeping people healthy. Not in treating, not in reimbursing private hospital when somebody falls sick. That will be distorting the whole expenditure. Even today, the goal has been 2/3 of expenses should go on primary health care. We are still around 50%. Because you have all these schemes coming up, reimbursing hospital admission, hospital care, and that will distort how we look at health care. Family is the center of health care. And this is an example from maternal child survival intervention. 90% of action for saving lives of women and children takes place at home. We have a nutrition excellence center, exclusive breastfeeding, early initiation of breastfeeding, complementary feeding, oral rehydration therapy, hand washing, consuming iron folate in pregnancy, in adolescents, in children, insecticide treated nets, use of contraceptive, all take place at home. Decision is taken in the family, action is at the family level. Even in complications, pneumonia is detected in the family. Early diagnosis is done in the family, then they take the child to the hospital, go to the hospital late, it's too late for saving life of a mother or a child. So family need to be brought back to the center of health care. And this is my favorite quote. Many of you must have heard it many times. There I am standing by the shore of a swiftly flowing river, and I hear the cry of a drowning man. So I jump into the river, pull him to the shore and apply artificial respiration. Just when he begins to breathe, another cry for help. So back in the river again, reaching, pulling, applying breathing, and then another yell again and again. I am so busy jumping in, pulling them to the shore, applying artificial respiration, that I have no time to see who the hell is upstream, pushing them all into the water. And this is what preventive medicine is. We are opening more AIIMS or more medical colleges, but we are not addressing what is to be done for primary health care. And what will happen? This will happen. You have disease burden, you are putting more and more patients, and this is the healthcare system trying to push the cart, and there is so much of burden he has to carry, he is hanging in the air. He cannot move. Both of them. Both of them. This is what will happen to, this is happening to healthcare, and more of it will happen to healthcare if you don't do. Focus on the family and focus on primary healthcare. SDG is an excellent opportunity. Some people, take out some of the SDGs saying that these are important for health. I say every SDG is important for health. 16 of them. 7 of them are environmental goals. We are always fighting with environment. For last few days it has been raining. We can go out and breathe. Otherwise you feel suffocated when you go out. You can't go for exercise because you do more harm doing exercise in a polluted air environment than sitting indoors. So even healthy practices have been converted into unhealthy practices because the environment has been damaged. Poverty goals. We all know poverty and ill health have a symbiotic relation. Inequality. We talked about inequality in healthcare. Inequality doesn't come from healthcare. It comes from other factors. Then you have 2 goals related to peace. I have worked in Iraq. I have worked in Somalia, and I understand how important it is to have peace for health of the people. I remember in Somalia we used to go to the gangsters who were fighting. Please sir, stop the fight for two days. We will give antenatal care and immunization to children. And they would stop. So our workers will go and vaccinate. But your outreach is limited. You have to talk to these gangsters, otherwise your workers will get shot. In Pakistan, many of the polio team workers were shot because of the unrest. So peace is very important. And the goal is ensure healthy lives and promote well-being of all at all ages. That is the goal. It is not disease like MDGs were disease and mortality. It is Jeevem Sharda Shatam, Prabhavam Sharda Shatam, Shunayam Sharda Shatam. That is the goal. But when it comes to converting into targets, we again look at diseases. So the goal is very clear. But when it comes to SDG targets, we have again gone back to the diseases. And that is what happens from Alma-Ata to New York to the reality.
Actually, the translation of this survey, I want to surprise to this one.
Come from there.
Promote well-being problem.
Yeah. And this slide is to emphasize again the contribution of family. Fortunately, you have costing done. How much is the contribution of family in ill health? The Lancet Commission on Women and Health put the value in India, 213,000, and this is a figure of I think about 12 years old. Today it will be more. 213,000 crores, most of it is done by women, but men, we can take some credit. 38,000 is contributed by men and 175,000 is contributed by women in the family. Look at the total government expenditure. I looked at the latest national health account, 169,312 crores, including center and state. Women's contribution on health care of the sick in the family is much more than the whole of state and central government put together. We have to strengthen that, we have to recognize that and do more to empower families. When you want to increase agriculture production, where do you go? You go to the farmers. क्योंकि खेतों में अनाज पैदा होता है उनके लिए सर हेल्थ की बात करते हैं हम करते नहीं हम तो हेल्थ सिस्टम की बात करते हैं प्राइमरी हेल्थ केयर से डोर स्टेप What doorstep? Health is produced inside the doorstep. Go there, change their behavior, make them more empowered. And education is not related to literacy. There are uneducated people who are more wise than you and me, but they were not fortunate to be born in the family where we were born. So please bring this back. Family has to be in the center if you want to achieve health for all. Good policy, very good. You look at any policy, any guideline in India, one of the best in the world. Problem? Implementation. We are not very poor in implementing. Some excellent people, we have access to PCM, we have access to other institutions, the best brains in the world, they will come and write down the policy. But that policy and guideline will stay in the shelf. Reality is very different. And we will hear more about it from Abhay. Lack of evidence in implementation, no focus on reaching the last beneficiary. And I teach leadership, as Kapil said, the best example of good leadership and good management is housewife management. Everybody gets food. He tells me to buy something from the market on way back from work, I forget, but I still get my dinner. Every child gets what he or she needs. Everybody in the family gets it. We have to bring that approach to healthcare. Everybody should get what he or she needs, irrespective of the resources. Accountability and implementation framework is lacking. When we were working on the policy, we prepared accountability, and Abhay will remember, implementation and accountability framework. It did not move beyond the first desk in the ministry. But then when it went to Prime Minister's office, somebody said NHSRC has prepared implementation accountability framework. Frantic call to me in NHSRC, sir, wo kahan hai? I said, we had sent it to you. Look at your file. No, sir, please send it again. And then there were feverish activities. Every division, every joint secretary looking at where his or her name is. Accountability at that level, not at the health worker. What happens? Deaths after measles, first person to be terminated is ANM. Who is releasing money? Who is providing training? Who is providing resources? Who is providing infrastructure? They are never touched. So accountability we had put at the ministry level or at the state and directly, but even after that it didn't move. So you had the policy release without accountability implementation framework. Implementation research needs more attention, and I see that change now, that you have more and more. And I was part of the core committee on National Health Research Policy last year. We have emphasized implementation research. It has been included. My friend from ICMR, has it come out? National Health Research Policy. I don't know if it is still in the making. So that policy needs to focus more on implementation research. My last question to residents. Where is this? Look at this tombstone. Whereas इसमें लिखा भी है नाम, अगर आप ध्यान से पढ़ोगे तो you will be able. I don't know if you can see, it is probably too small. So the pioneers of health for all and bringing the focus on primary health care. Dr. Haftan Mala, you won't get the prize, but I'll give you what I have in my hand. This is a golden pin. So I'll give you that. Where you go back to your residency days, and so this is the tombstone of Haftan Mala, who, along with Henry LeBoy, UNICEF Executive Director, they were the stalwarts of Alma Ata Declaration Primary Health Care. Brought everybody together, and it came into. But what happened after that? WHO dropped the ball. They don't remember. I was very happy they remembered health for all now. But they dropped the ball. UNICEF continued, and UNICEF was criticized. They were criticized for selective primary health care, growth monitoring, oral rehydration, breastfeeding, and immunization. And then they added the food fortification, family planning, and those 3 F's were added to it. UNICEF did not drop the ball. And those of you who worked closely with UNICEF in 90s will remember UNICEF had what was called mid-decade goal, not MDGs, Millennium Development Goals. Mid-decade goal they had spelled out. There were 14 goals globally and we added 4 to India, and there were 18 goals on which UNICEF was working. So UNICEF did not drop the ball, but WHO, the pioneer, the Hafden-Mahler vision, they dropped it. And those of you who have been going to WHO, I have seen Hafden-Mahler. He had superannuated, but he used to come to WHO headquarters to chair various meetings and contribute. So, historically, what is decided in Alma-Ata, coming to the title of my talk, what happened in New York and what is in reality, there is a huge gap. Thank you so much. If there are any questions, I can take those questions. Thank you.
So your phone? Thank you so much for a very inspiring presentation. I think questions we can have at the end of the second talk by Dr. Abhay Shukla. I don't think there's anybody from UNICEF or WHO here. Please.
You nominate somebody because you gave the answer. Yeah. No, I have more in my pocket. You can keep it.
On a lighter note, there's a saying that WHO knows everything but doesn't do anything. On the other hand, UNICEF doesn't know anything but does everything. So it's a good thing that these two organizations came together, and that's why I think some action has happened on Health for All. Now I invite Dr. Abhay Shukla, who is an alumni of CC and undergraduate from AIIMS only. Dr. Abhay Shukla is a public health physician. He has been working on health issues in collaboration with People's Movement and grassroots NGOs in Western India for over two decades. It must be more than that, sir, now? 3 decades now. So he's a senior program coordinator for Sathi, an NGO at Pune. He's one of the national conveners of Jan Swasthya Abhiyan and also a member of National Health Mission Advisory Group for Community Action. My introduction with sir was when I was a junior resident, 2004, I think. So NRHM was being planned at that time, and Dr. Pandav took us along those meetings that were held, and some of them were held in CCM, some in the Christian Medical Association office. To be honest, I didn't understand one word of it at that time. But now in retrospect, we understand what was the dialogue that was happening at that time and how it was being implemented in NRHM subsequently. So thank you so much for that experience, sir. Over to you, sir.
Some of these lights are there
sure.
all together. Right? It won't be possible.
I'll ask, sir. Yes.
I think something needs to be done to. Okay, yeah. Okay. So, yeah, that's better. Thanks. But please, nobody, I hope, will sleep. So, respected Professor L.M. Nath, respected Dr. Pandav, all colleagues from the Center for Community Medicine and also from IPH and IAPSM, it's really a great honor to be given this opportunity to speak. And after so many illustrious speakers and my seniors on the dais, I will try to bring you into a little, I will say, not exactly abrupt, but a sharp encounter with reality on the ground. And however, like Dr. Sanjeev, I am also an optimist. So I'll try to point out, as you can see, my title is Advancing Publicness. And I would request you, especially the residents, to reflect on this term publicness. It's not just public, it's publicness. It's a concept which we need to discuss. I'll try to discuss about it a little. Regulating commercialization, ensuring the right to health for all, not just health for all, but the right to health for all, and learning from the COVID-19 pandemic in India. And that is going to be my focus. The COVID-19 pandemic was a huge storm with many dark clouds. And we know how many people lost their lives and how many more people suffered. But there was a silver lining also. And that silver lining is what we need to take forward to advance publicness in the health system in our country today. So I'll start with a quote from Paul Farmer. How many of you have read about Paul Farmer? Only 2, 3, okay. Those who have not, just go to Google and type Paul Farmer, and you'll find a remarkable range of literature written by this person. And so his quote is that we find ourselves at a crossroads. Either healthcare can be considered a commodity to be sold, or it can be considered a basic social right. It cannot be comfortably considered both of these at the same time. This is a very important point, and we have to make a choice. Do we consider healthcare to be a basic human right, or do we consider it something to be bought and sold in the market? And that is what I will be talking about. This is the choice that we now need to make, especially in the light of the COVID pandemic. During the COVID-19 pandemic, I am not going into the figures and the whole debate on underreporting and so on. But I'll be talking about Maharashtra, so I just wanted to give a little context. Maharashtra was the state which was worst affected during the COVID-19 pandemic in terms of numbers of cases, in terms of numbers of deaths, and also in terms of COVID case fatality rate. So out of 100 COVID patients, how many died? We were top 5 states in terms of numbers of deaths, and you can see that the situation was quite grim in Maharashtra. And this one state had almost 1/3 of all the COVID deaths in the country. So this was the grim part of the picture. But in this very grim situation, something unique happened. Something unprecedented happened. And that is what I call the silver lining. The society responded to this epidemic in very remarkable ways. Firstly, at the ground level, we saw so many heroines and heroes, and there were more heroines than heroes. This is Renu Vasavi, an Anganwadi worker in Nandurbar, which is one of the most remote districts of Maharashtra. She used to row 14 kilometers on her boat every day to reach the children in the Anganwadi so that she could feed them. This is Dr. Manisha Jadhav, a public health doctor, a doctor working in a TB hospital in Mumbai, and she worked till the day before her death when she died of COVID, serving people. This is Jitendra Shinde, an auto rickshaw driver in Kolhapur, who transported thousands of COVID patients free of charge. He was not a rich person. He was not a person who had a huge amount of money, but he considered it his duty to transport patients. This is Pyare Khan from Nagpur, who spent more than 1 crore rupees from his own pocket, his own resources, to provide oxygen to hospitals in Nagpur. So these are just a few examples, but I want to call your attention to the fact that these were only the tip of the iceberg. These individuals, these heroines and heroes, were representative of a much broader phenomenon, and that is what I would like to share with you. In this pandemic, the 3 parts of our health system, 2 parts are well known: the public health system and the private healthcare sector, and the 3rd part is people themselves, which we usually forget about, or we don't consider them to be part of the health system. We think they are some, our beneficiaries or our users, but they were central to the entire health effort during COVID. And this is what I would like to emphasize. When we talk about public health, we're talking about the public. We're not talking about government health, we're talking about public health. And public health with both a capital P and a small p also means people. So in the interactions between these 3 important components of the health system, I'll talk about 5 new phenomena or quite innovative phenomena which emerged. The first is what I call health solidarity. People came together on an unprecedented scale to tackle the epidemics. I'll talk about this. The second was, and I'm adding to what Dr. Sanjeev Kumar said, what I call co-production of health. Health cannot be produced by health systems alone, by government health services. It can also not be produced only by families or communities working in isolation. It can only be co-produced. I'd like to emphasize this point. Health can only be co-produced in the optimal way, otherwise it will remain a fragmented form. And this happened in COVID, I'll tell you how. The third was social accountability of private hospitals. Note the point, I'm talking about private hospitals. We keep talking about social accountability of public health systems, but in COVID, we saw these phenomena emerging. Interventionist regulation of private healthcare, I'll talk about it, which is not just routine regulation, and modified public-private healthcare arrangements between the public health system and the private sector. These 5 innovative kinds of public phenomena, public health actions emerged during COVID in Maharashtra, which I will describe very briefly. And these are all important, aspects of the COVID pandemic. Health solidarity. Across Maharashtra, there are hundreds of stories, and there are probably many such stories in other parts of the country also, where people came together. They set up isolation centers in a local school. They set up quarantine centers in the local panchayat bhavan. They ensured food grains, delivery of food grains, which was so important. They fed migrant workers for weeks and months together. This is not happening because of some government order from above. These are people acting from below. And of course, they also help to strengthen measures like immunization and demand also right to health, so life-saving services. And here you can see this is a demonstration which is taking place in Pune city of health workers and social workers asking for delivery of basic life-saving care during COVID. So all these kinds of action took place. We published a book on this called Dakhal, which I can share with you. The second related aspect, new phenomenon which emerged, was participatory initiatives for co-production of health. So on one hand, there was a very centralized approach. You know about this. The lockdown was declared with 4 hours notice, unprecedented, a country of 135 crore people, and you know what happened. Anyway, without going into that, parallel to these centralized initiatives, there were a huge range of participatory initiatives. You would have heard about the Dharavi model. I will not talk about it because perhaps you already know about it. But that is one example of these kind of co-production initiatives. And these involve both frontline health workers and grassroots level organizations, panchayat members, volunteers on large scale, women's groups, various kinds of social groups came together and forged what I call public-public partnerships. You can note this term. It's not a popular term. It should be actually much more popular than the well-known term. Huge number of public-public partnerships came up, and these saved people in many places. And this co-production of health appeared spontaneously. It taught us public health experts something which we should have known long back. As a public health expert, for the first time, I was forced to think, yaar, ye ho kya raha hai? What is going on? There's something new, which I need to understand. And then I started searching around and came up, that this is actually something which we should have known, happening under the pressure of COVID. I'm just giving you one example, which was done by our organization, Sathi. Rural public hospitals across Maharashtra, in 40 different blocks in different parts of the state, ranging from Gadchiroli to Nandurbar to Kolhapur to Palghar. We actually reached out to public hospitals where people were struggling to get non-COVID care also, not just COVID care. The main public hospital had been converted fully into a COVID hospital. And then what about people who have a delivery, who need dialysis, who have an accident? Where do they go? So we've set up these, help desks, and something like 80,000 patients were actually, guided and helped through these help desks. The main point was, again, this is not because of some central order. It came up. And in place after the initial experiment came up in Bhudargarh block of Kolhapur district. Back of nowhere, nobody knows about this place, but they came up with this innovation, and it was rapidly upscaled because it was the need of the time. So co-production, local civil society groups and frontline health services coming together. So I'm not going to the detail of the idea of co-production. I think maybe Dr. Sanjeev, we can have a discussion about this in CCM sometime. It will be very interesting that, why this co-production is so important. And a kind of democratic collaboration involving health systems, frontline health workers who need to be respected, valued, and also properly compensated and supported, and of course, kind of recognizing the essential role of the state. So we are not abdicating the state. When we talk about co-production, it doesn't mean यार लोग अपना अपना कर लो, which we used to joke and say कि तुम्हारा स्वास्थ्य तुम्हारे हाथ में, तुम्हारे पैसे सरकार के हाथ में. No, that's not what we mean by co-production. So the state has a role, the public health services do have a role, but people also have a role. When they come together, that is the combination which makes change happen. That is co-production. But it has to be on the basis of equalization of power. A dialogue can take place only among equals. It's not orders कि डॉक्टर साहब ने आदेश दे दिया और फिर लोगों ने वो करना शुरू कर दिया. That is not co-production. It's a different kind of relationship. The second important front which we saw emerging was social accountability of private hospitals. Private hospitals operate in a market framework. And if you go and ask a question in a private hospital, बोलेगा अरे आप कौन हो हमसे सवाल पूछने वाले, आपको सर्विस लेनी तो ले लो, नहीं तो भाग जाओ. Get lost. This is the standard understanding of a private hospital. So we emphasize the fact that private hospitals also have social obligations. And during COVID, when the rates were regulated for COVID care, they have to be implemented and they have to be observed by private hospitals. So anyway, as Jan Swasthya Abhiyan, we organized a state level public hearing on private hospitals. I think this might have been one of the first events of its kind. Public hearing public services पे होते हैं, public hearing private hospital पे शायद पहली बार हुई, in which dozens and dozens of patients talked about the testimonies of overcharging of in private hospitals, denial of patients' rights, detention of dead bodies to extract higher bills, and not giving various other basic care under AIIMS Bharat, which is supposed to be given but was not being given. So then Sati came out with a book called Patients' Voices During the Pandemic, and I'll leave a copy of this for CCM for you all to read. It has 23 patient testimonies and then an analysis of what it's available on the internet free. You can download it. Yeah. So it's on the Sati website. So patients' voices, what actually happened to patients in private hospitals? Very few documentations took place. We try to do that and then we give an analysis of what happened and how this needs to change. Coming to this, we did a large civil society survey. मैंने अपने लाइफ में बहुत सारे सर्वे किए. This is a unique survey. 15 दिन के अंदर स्टेट लेवल का सर्वे 2500 प्लस रेस्पोंडेंट्स को लेके उसका रिपोर्ट भी निकला. शायद ऐसा कोई सर्वे मैंने तो अपने लाइफ में नहीं किया था. Because there was so much, such an overwhelming response. It was of course done online through Google, Google Forms. But anyway, we surveyed 2,500 plus COVID widows. Maharashtra has the largest number of COVID widows in the country. There are more than 20,000 young women in their 30s and 40s who have lost their life partners. You can imagine what is their situation if, in addition to that, they have lakhs of rupees of private hospital bills unpaid. What is going to happen? Anyway, so we surveyed these, families and COVID widows, and if you took the benchmark as rupees 10,000 per day, which is a huge amount for an ordinary family, 75% of these 2,500 plus families had been overcharged as per government rates. This is as per government rates. Then we did an in-depth analysis. हमारे देश में ना सारा स्टडी जो है ना पब्लिक हेल्थ सिस्टम पे होता है और प्राइवेट सेक्टर विच प्रोवाइड 70% ऑफ केयर उस पर कोई स्टडी ही बहुत कम होते हैं. दिस इज अ पैराडॉक्स. So we said, यार ठीक है, हमको थोड़ा देखना चाहिए क्या हुआ इन पेशेंट्स का. So we actually went through each and every hospital bill for 100 patients, and those are not small bills. Those are bills which run into pages and pages of medicines and procedures and so on. Anyway, we did that analysis. Now here you can see that the green bars represent what was the expected expense in the private hospital as per government rates, about 7,000 to 8,000 rupees per day, and the orange bars are what they actually spent as per the hospital bills. We have documentary evidence for each patient. It was 33,000 to 40,000 rupees per day. This was 4.3 to 4.9 times, almost 4.5 to 5 times higher, 500% of what they were supposed to be charged. If you just calculate the entire annual income of a person in Maharashtra, and that is like an average person, not a poor person, an average income, it was 5 days of hospitalization will wipe out your entire year's income. So this was the scale of overcharging which took place in COVID. I am surprised that, have we forgotten about this? Or was Maharashtra the only place where this was taking place? I have heard about Delhi. I have heard from friends in Delhi about what is happening in some of the Delhi hospitals. I have heard about Chennai. I have heard about, various other places also. So this is something which we tried to document, and then we didn't stop with documentation. Then in various places, what are called Santap Sabhas, or, loosely translated, you can call them anger assemblies, where COVID widows and their family members came up and said, we have a hospital bill of 15 lakhs, 18 lakhs, 20 lakhs. What do we do now? Our loved one has gone, and how do we, this is gross overcharging. Something needs to be done. You'll ask, was something done? Yes. We met the health minister of Maharashtra, and I with an MP from Maharashtra, Supriya Sule. And we told him, look, this kind of huge overcharging has taken place. You have to do an audit. And we have to actually reimburse money which is being charged by people by the from people by the private hospitals. Not an easy task, I can assure you. आप private hospital में आपने पैसा भर दिया ना, अगले दिन जाके बोलिए सर 5 रुपए ज्यादा चार्ज हो गया, आपको 5 रुपए भी नहीं मिलेगा आसानी से. हाँ? In these cases, we did audit after audit for almost 500 cases. In 63 cases, we got a refund. The average refund amount was 25,000 rupees. People were refunded up to 1.5 lakhs from the private hospitals because of this audit. Social accountability of private hospitals is possible. It's not a dream. And it's something which has to actually become part of our agenda if we are talking about public health. The fourth phenomenon which emerged, which was by the state government, was interventionist regulation of private healthcare. You see, we keep talking about regulation of private hospital. उसमें क्या आता है? Minimum standard, अच्छा कितना स्क्वायर फुट एरिया होगा रूम का, ओपीडी में कितना जगह होगा, ह्यूमन पावर का क्या स्टैंडर्ड होगा, एक बेड के पीछे कितने नर्स होंगे. This is all fine. This is not sufficient. We have not yet talked about the core content of private healthcare and how that needs to be regulated. And that's why in COVID we had what we call something like market failure से आगे बढ़ के market disaster होने वाला था. People would have started dying on the roads despite the fact that there were beds in private hospitals. So then Maharashtra was the first state to regulate the rates for treatment. After that, 15 other states, including Delhi, regulated rates in private hospitals. But in Maharashtra, 80% of beds for both COVID and non-COVID patients were regulated. Attempts were made. And there's a shift from what you can call minimalist regulation. थोड़ा infrastructure standard बना दिया, थोड़ा सा और हो गया, to what I call interventionist regulation, because this was reshaping the market. It was saying rate इससे ज़्यादा charge नहीं करना है. So this was another important thing. And then public-private healthcare arrangements were also reshaped during COVID. In our country, a lot of the public-private health arrangements in the healthcare sector, which we call PPPs, are in the direction of handing over public resources to some private providers. And the market is not actually very much, influenced by that. तो मार्केट रेट में चल रहा है वो चलता रहता है और थोड़े पब्लिक फंड्स किसी प्राइवेट हॉस्पिटल को दे दिए जाते हैं, लोगों को थोड़ी बहुत केयर देते हैं, कितना देते हैं क्या होता है वो आप लोगों को भी पता होगा. So these new kinds of arrangements took place where the whole health insurance scheme was universalized to cover 100% of the population in Maharashtra, and the state government took control of 80% of hospital beds in private hospitals, so that people would get care. So we can see if the state wants to act, it can act. Please underline this point. It's not that अरे private hospital के बारे में तो कुछ नहीं कर सकते. If the state has the political will, it can be done, and in COVID that emerged, although in a temporary way. Now you will say, अच्छा ठीक है ये तो COVID में हो गया, उसके बाद क्या? It's not. So it has. Emerson has said, the man's mind stretched to a new idea never returns to its original dimensions. एक बार आपने एक सपना देखा तो आप उसको भूलोगे नहीं. एक बार आपने विजन देखा तो आपको उसको भूलना नहीं चाहिए. So now we have to continue this. Of course, that situation is gone, and it's good that it is gone. But the lessons from that should not be lost. And here I'll just point out a few things which we are doing. We talked about comprehensive primary health care. आज देश भर में हेल्थ एंड वेलनेस सेंटर सेटअप हुए हैं, लेकिन उन हेल्थ एंड वेलनेस सेंटर्स के साथ में जन आरोग्य समिति भी सेटअप होनी चाहिए थी. लिखा है कागज पे लिखा है सारे डॉक्यूमेंट्स में, पर हो नहीं रहा है ग्राउंड पे. सो इन महाराष्ट्र वी टुक दिस एज ए चैलेंज. हेल्थ एंड वेलनेस सेंटर को अगर एक्टिव करना है तो जन आरोग्य समिति उसका बेस रहेगा. And we have set up hundreds of Jan Arogya Samitis in places where they were dysfunctional, non-functional, only there on paper, whatever. And as a result of that, many primary healthcare services started getting delivered in Pune district, in Nandurbar district. So diabetes, high blood pressure patients were supposed to be getting free care. They were not getting it earlier. अभी वो मिलने लगा. जन आरोग्य समिति members now regularly visit the health and wellness center, talk to the CHO. CHO को भी बेचारे को कोई आइडिया नहीं उसको क्या करना है. उसको कुछ तो थोड़ा सा ट्रेनिंग दे के बैठा दिया वहां पे. उसको इतना पता है मुझे ओपीडी चलानी है. इसके आगे अरे भैया उस 13 सर्विसेज की लिस्ट है. आपको जो है ना कॉम्प्रिहेंसिव केयर देनी है. सिर्फ ये नहीं कि खांसी जुकाम का सर्दी का इलाज कर दिया. So all these so this is one thing which we are now continuing, working with Jan Arogya Samitis to energize the health and wellness centers. And then coming back to the private sector, patients' rights. Now, as you know that the Union Health Ministry and before that the National Human Rights Commission adopted a patients' rights charter. And this patients' rights charter has been updated by the Union Health Ministry in 2021. It has 20 patients' rights which apply to private hospitals also. How many of you have seen the 20-point patients' rights charter of the Union Health Ministry? I'll give that set of earrings to you. डॉक्टर संजीव आपने तो मेरे पास ही उसको August 2021, I shared the link with you. 20 patients' rights which are applicable to each and every private hospital and public hospital in this country have been circulated by the Union Health Ministry. Based on the COVID experience, you cannot detain the dead body of a patient. It's illegal. You cannot order the patient to buy medicines only from the pharmacy in the hospital. It's illegal. The patient has a right to decide where they want to get their tests done or where they want to get their medicines from. Transport, patient transport का right है, right to information, a right to second opinion, a right to all records and reports. There are 20 patients' rights. So we try to pursue this in Maharashtra कि अभी कोविड से हमने जो कुछ झेला वो तो झेला, प्राइवेट हॉस्पिटल में जो कुछ हुआ वो हुआ, लेकिन अब इसके बाद कम से कम पेशेंट राइट्स तो लागू होने चाहिए. एंड द महाराष्ट्र गवर्नमेंट केम आउट विद एन ऑर्डर इन 2021 फॉर इम्प्लीमेंटेशन ऑफ पेशेंट्स राइट्स, द पेशेंट्स राइट्स चार्टर, एंड नाउ वी आर फॉलोइंग दिस अप in city after city of Maharashtra. Sangli, Pune, Nashik, these are the cities where we have started actually carrying out a campaign, visiting the private hospital, asking the hospital management, भाई साहब आपका patient rights charter किधर है और आपका rate display किधर है. That's another very important point. Rate display. ये बात बोलते हैं हम मार्केट में ऑपरेट करते हैं, तो मार्केट का पहला प्रिंसिपल ना ट्रांसपेरेंसी होता है. आप किसी रेस्टोरेंट में जाते हो तो सबसे पहले क्या देखते हैं, क्या देखते हैं रेस्टोरेंट में? मेन्यू कार्ड देखते हैं ना, और मेन्यू कार्ड भी उर्दू में पढ़ना होता है. मतलब फ्रॉम राइट टू लेफ्ट पहले रेट्स देखते हैं कि इधर मसाला डोसा कितने का, चाय कितने की और वट पास्ता कितने का, एंड देन यू डिसाइड. So if a restaurant can give their rates, if a barber shop can give their rates, of course I know a hospital is much more complex, but at least the basic rates like bed charges, like basic outpatient consultation charges, they should be displayed. This is in their patients' rights charter. तो इसका हमने फिर फॉलोअप करना शुरू किया, and I am happy to inform you that in dozens of private hospitals they have started displaying the rates, they have started displaying the patients' rights charter, but we have a long way to go. There's no reason why this cannot be done in other states also. Now this is my favorite slide about our healthcare system. इसमें दो पहलवान हैं. I hope all of you understand Hindi because दो पहलवान आमने सामने हमारे हेल्थ सिस्टम में. The big पहलवान is profit logic. It says कि भाई आपके पास पैसे हैं तो आपको हेल्थ केयर मिलेगी, आपके पास ज्यादा पैसे हैं तो ज्यादा हेल्थ केयर मिलेगी, आपके पास बहुत ज्यादा पैसे हैं तो इतनी ज्यादा हेल्थ केयर मिलेगी जिसकी आपको जरूरत भी नहीं है. आपका यूट्रस भी निकाला जा सकता है, आपका सिजेरियन भी बिना जरूरत के हो सकता है, और भी बहुत सारी चीजें हो सकती है, और आपके पास पैसे नहीं है तो आपको कोई हेल्थ केयर नहीं मिलेगी. दिस इज व्हाट द प्रॉफिट लॉजिक सेज. ऑन द अदर हैंड द सोशल लॉजिक सेज हेल्थ इज अ ह्यूमन राइट, हेल्थ केयर इज अ ह्यूमन राइट, एंड एवरी ह्यूमन बीइंग, it may be a Dalit, an Adivasi, a rural person, a woman, a man, any person has a right to basic health services, and that is what health for all is about, my friends. उसके बिना health for all नहीं होगा. जब हेल्थ का राइट होगा, जब हेल्थ केयर का राइट होगा तो हेल्थ फॉर ऑल भी होगा. उसके बिना इस देश में तो कम से कम होना मुश्किल है, ऐसा मुझे लगता है, बट वी कैन डिस्कस दैट. बट आई एम जस्ट नाउ कमिंग अ बिट टू द कमर्शियलाइजेशन पार्ट. Until now I talked about what people did and what public health systems did. What did the private sector do in COVID? I gave you a little small snapshot of the overcharging. Now let's come to another interesting statistic. This is from 2022, latest figures. हिंदुस्तान में कितने डॉलर बिलियनर्स हैं, कोई बता सकता है? India has how many dollar billionaires? And where do we stand in the list in the world? No, thousands तो नहीं है. Yeah, you're close. So if you make a list of all the countries, US, China, UK, Germany, Japan, France, etc., Brazil, तो इंडिया का नंबर किधर आएगा लिस्ट ऑफ बिलियनर्स में, कितने बिलियनर्स हैं? टॉप 10 इज ओके बट करेक्ट। थर्ड अवार्ड दे सकते हैं उनको। वी आर मोर देन यूके, वी आर मोर देन जर्मनी, वी आर मोर देन जापान, वी आर मोर देन फ्रांस। आइए आप इसको ले सकते हैं। तो ओके, लेकिन हमारे पुराने अच्छा बाद में ले, चलिए ले लीजिए। लेकिन असली कहानी इससे भी गहरी है। वेयर इज द वेल्थ ऑफ दीज बिलियनियर्स कमिंग फ्रॉम? इतने सारे $166 बिलियनियर है, 166 in this country. India is not exactly a poor country. India is both a rich country and a poor country. अब हिंदुस्तान के बारे में जो सेंटेंस बोलेगा ना उसका ऑपोजिट भी सही होता है, ये तो आपको पता होगा। So where is their wealth coming from? So 31 of these dollar billionaires have earned their wealth from manufacturing, 16 from information technology, 16 from diversified industries, which means like Adani and Ambani, 15 from fashion and retail. But where is the top slot? The maximum number of wealth in this country is being made from healthcare. Are you aware of this? We are talking about public health. Resources नहीं है क्या इस देश में? The 7 new dollar billionaires have been added in just 2022. उनका पैसा किधर से आ रहा था? वो क्या कर रहे थे? वो वैक्सीन बेच रहे थे, वो दवाइयां बेच रहे थे, और उन दवाइयों से थोड़ा बहुत पैसा नहीं बना। Fortunes have been made, and Adar Poonawalla is 4th on the Indian list today. I'm not saying that you should not make manufacturing. I mean, of course, we need the private sector. The private sector does a role. But what is happening is that today the amount of wealth that has been accumulated and is continuing to be accumulated by the private healthcare sector is becoming unacceptable. 9.37 trillion rupees. अगर इसको हम गिनने बैठेंगे ना तो अपने लाइफ टाइम में गिन नहीं पाएंगे। This is the amount of wealth that just the healthcare billionaires in India have today. आप बोल रहे हैं हिंदुस्तान में रिसोर्सेज नहीं है पब्लिक हेल्थ के लिए। रिसोर्सेज बहुत हैं, लेकिन वो कहीं और हैं। द टोटल बजट, डॉक्टर संजीव, मैंने भी ये NHA से ही लिया है। मे बी द फिगर आर लिटिल डिफरेंट फ्रॉम व्हाट यू हैड शोन, बट देयर इन द सेम बॉल पार्क रेंज, इज अबाउट 2.5 लाख करोड़। डॉलर बिलियनियर्स का वेल्थ कितना है? ऑलमोस्ट 10 लाख करोड़। 10 लाख करोड़। और पूरे हिंदुस्तान के सारे सरकारों का हेल्थ बजट मिला के है 2.5 लाख करोड़। 4 गुना का फर्क है, छोटा फर्क नहीं है। तो अगर इन डॉलर, जो हमारे डॉलर बिलियनर्स हैं, और ये सिर्फ बिलियनर्स की बात कर रहा हूं, मैं छोटे मोटों की तो बात ही नहीं कर रहा हूं, सिर्फ बिलियनर्स की बात कर रहा हूं। इनके ऊपर अगर एक 10% का टैक्स लगा दिया जाए तो हिंदुस्तान के पब्लिक हेल्थ सिस्टम का चेहरा बदल जाएगा। जिन हॉस्पिटल्स में, PSCs में दवाई नहीं मिल रही है ना, वहां दवाई मिलने लगेगी। जहां पे स्टाफ नहीं है, आशा को पेमेंट नहीं मिल रहा है, जहां AIIMS कॉन्ट्रेक्चुअल बेसिस पे रखे, उनको रेगुलराइज कर सकते हैं। कितना बदलाव हो सकता है? सो दिस इज अ क्वेश्चन ऑफ रीडिस्ट्रीब्यूशन। द टास्क बिफोर अस इन द पोस्ट कोविड इंडिया एंड पोस्ट कोविड वर्ल्ड इज रीडिस्ट्रीब्यूशन. We have to bring redistribution back on the agenda. All public health is based on redistribution. Please note this. It is the sick who are supported by those who are well. It's the well-off who support those who are less well-off. That is the principle of public health. So that redistribution needs to be brought on the agenda. But what are we doing? Niti Aayog. Niti Aayog has come out with a report recently, 2021. I call it pouring petrol to put out the fire. अगर आग लगी है तो आप क्या करेंगे? पेट्रोल डालना चाहिए ना, सही है ना? तो ऑक्सीजन भी दे सकते हैं। तो अगर प्राइवेटाइजेशन प्रॉब्लम है तो आप क्या करेंगे? प्राइवेटाइजेशन को कंट्रोल करेंगे, रेगुलेट करेंगे, या उसको और बढ़ाएंगे? एंड दिस रिपोर्ट सेज, द एंटायर रिपोर्ट, प्लीज रीड दिस रिपोर्ट, इन्वेस्टिंग इन इन्वेस्टमेंट अपॉर्चुनिटीज इन इंडिया हेल्थ, शायद आपने पढ़ा होगा। You heard that. Is the word regulation mentioned even once? It's not. Anyway, okay, let me complete. The word regulation of private healthcare is not mentioned even once in that entire report. And I've read it and I've searched for that word, And this is despite the fact that the experience during COVID of the private healthcare sector आम लोग जानते हैं क्या हुआ है प्राइवेट अस्पतालों में। हमने सर्वे किया वो एक अलग चीज है, लेकिन ग्राउंड लेवल की रियलिटी लोग जानते हैं, सामान्य लोग जानते हैं, भले ही कोई एकेडमिक जाने या ना जाने। और आपने उसमें रेगुलेशन का शब्द भी नहीं इस्तेमाल किया। व्हाट इज द रिपोर्ट सेइंग? वी शुड फर्दर एक्सेलरेट मल्टीनेशनल इन्वेस्टमेंट्स एंड डोमेस्टिक इन्वेस्टमेंट्स इन प्राइवेट हेल्थ केयर. That is the main focus. Public hospitals should be handed over in PPP mode to private operators to run private medical colleges. We are rolling out the red carpet to transnational and domestic investors, and I've just shown you the picture of our domestic healthcare billionaires. लेकिन इनके पीछे और भी बड़े लोग हैं। आप इस समय हिंदुस्तान में जितने बड़े हेल्थ केयर कॉर्पोरेट्स हैं, उनका वर्क जो मेन कैपिटल है, it has been either they have been taken over or they have huge stakes of multinational investors. You take Medanta, you take Fortis, you take Apollo, all of them. So these are huge amounts of multinational capital is coming into this country. And what does that lead to? It leads to corporatization of healthcare. And this is another concept that I would request you as public health experts to sit up and look at. This is not a minor phenomenon. ये हमने इसकी तरफ ध्यान ही नहीं दिया कि ये कुछ चल रहा था पिछले 15-20 सालों में. You might be aware that multinational investments in India's healthcare sector increased by 100 times between 2002 and 2014. 100 times. और आज हमारे देश में कॉर्पोरेट जो हॉस्पिटल्स हैं, दे आर नॉट ओनली द कॉर्पोरेट हॉस्पिटल्स आर डूइंग वेरियस थिंग्स, वो तो एक अलग कहानी है, मतलब वो भी एक पार्ट है, बट दे आर इन्फ्लुएंसिंग द एंटायर सेक्टर. स्मॉलर हॉस्पिटल्स आर शटिंग डाउन. Individual doctor-owned hospitals are finding it difficult to survive. Charitable hospitals are being turned more and more. आपको नाम उसका चैरिटेबल मिलेगा, लेकिन उसकी जो काम करने का तरीका है वो एकदम प्राइवेटाइज जैसा हो गया है, एकदम कमर्शियलाइज हो गया है. And Apollo, Fortis, Narayana, Max and Healthcare Global, these 5 big corporates had an increase of almost 80% in just a 5-year period. The doctors working, we have interviewed some of those doctors. Our book Dissenting Diagnosis, which I had released here in AIIMS, in the same boardroom, has documented कि उन प्राइवेट कॉर्पोरेट हॉस्पिटल्स में काम करने वाले डॉक्टरों की घुटन क्या है. उनको टारगेट दिया जा रहा है, उनको कार्डियोलॉजिस्ट को बताया जा रहा है कि आपका कन्वर्जन रेट बहुत कम है. आपका कन्वर्जन रेट मतलब पेशेंट आया तो उसका एंजियोप्लास्टी होगा कि नहीं, उसकी एंजियोग्राफी और एंजियोप्लास्टी होगी कि नहीं. 15% कन्वर्जन है, इसको 40% करना है. आपने पढ़ा होगा ईपीडब्ल्यू में, उसका एक इसके ऊपर आर्टिकल भी आया. दिस इज आर आर्टिकल ऑन ईपीडब्ल्यू ऑन कॉर्पोरेटाइजेशन इन प्राइवेट हॉस्पिटल सेक्टर इन इंडिया. आई एम नॉट गोइंग इनटू द डिटेल्स, बट कॉर्पोरेटाइजेशन इज द एक्सट्रीम एंड ऑफ कमर्शियलाइजेशन. जब कमर्शियलाइजेशन एकदम एडवांस स्टेज पर चला जाता है, तो फिर हेल्थ केयर को डिलीवर करने का प्राइमरी ऑब्जेक्टिव प्रॉफिट बनाना ही हो जाता है. एंड दैट इज व्हाट कॉर्पोरेट्स डू, एंड द साइड इफेक्ट इज गिविंग पीपल सर्विसेज. जैसे पब्लिक हॉस्पिटल का मकसद कभी भी प्रॉफिट कमाना नहीं होता, या होना तो नहीं चाहिए. हाँ, उसका प्राइमरी और मेन मकसद है लोगों को सेवा देना. तो कॉर्पोरेट उसका उल्टा है, उसका प्राइमरी मकसद है उसके शेयर होल्डर्स के स्टेक्स का शेयर बढ़ाना, उसका प्रॉफिट मैक्सिमाइज करना, और साथ में ऑफकोर्स लोगों को सर्विस तो देते ही हैं, लेकिन उसका क्या ये होता है वो हम देख सकते हैं. सो एनीवे, अनदर डॉक्यूमेंट व्हिच आई वुड सजेस्ट यू कैन रीड इज अबाउट व्हिच वी ब्रॉट आउट विद ऑक्सफैम इंडिया ऑन रेगुलेशन ऑफ प्राइवेट हेल्थ केयर इन इंडिया. Today, India is facing a regulatory stalemate. This is what we have noted. आपने अभी पढ़ा ना राजस्थान में क्या हुआ. I am coming to that. This is part of that process. The private sector has stonewalled, has completely refused to be regulated or to be engaged even with the public health system in any way which even mildly contains their profiteering. So अगर आपको हेल्थ इंश्योरेंस स्कीम में लेना है तो चलेगा, लेकिन उसके अलावा नहीं होता है. Anyway, I have a copy of this. I'll be giving it to the CCM library. Please, yes sir. Can I? हाँ. अच्छा, okay. I'll send you. It's available again on the internet, free. So I have to conclude now because we've run out of time. So today in our public health system, we see hyper centralized decisions, devalued frontline workers, and people are minimally involved. But in COVID, we have seen another possibility. It's only a possibility. If we let go of this, it will disappear or it will just become history. But if we start thinking about co-production of health, upgraded status of frontline workers, and expanded role for the public health system, we can think of a different future. People are usually detached from public health and become consumers. भैया पैसा दो और हेल्थ केयर ले लो प्राइवेट अस्पताल में. दिस इज द स्टैंडर्ड थिंग. But in COVID, we saw collective health actions. Collective health actions are the base of public health. Public health considers health and healthcare to be a basic social good, something which we do collectively. We have seen this happening. Private healthcare sector, I described about interventionist regulation and public-centered arrangements with private providers. And finally, social accountability of private hospitals. Private hospitals are also social institutions. Most of the private hospitals in our country have been set up with subsidies from the government in various forms, land, various other kinds of subsidies. Many of them, the doctors working there have been educated in public medical colleges like AIIMS, but there are so many others. हमने अपने मेडिकल एजुकेशन पे हमारे समय में डॉक्टर, आपको भी डॉक्टर संजीव आपको याद होगा, हमारी फीस क्या हुआ करती थी? मेरी 60 रुपए महीने थी. हम 60 रुपए महीने इस इंस्टीट्यूशन में फीस दे के मैं डॉक्टर बनाऊं.
50 रुपए होती थी एप्लीकेशन तो
There is huge public subsidy on me and all of you sitting here. So when we go out, we cannot say, I'll do whatever I want to do, I'll just go and work in a corporate hospital and make money and full stop. There is huge public subsidy that has gone into private hospitals in this country. We need to recognize that. And when we do all these things, we will be advancing what I call publicness. So it is not just strengthening the public health system, it's doing many things. Advancing publicness is the direction we need to take if we want to achieve health for all. This is my sincere plea to all of you. That is the direction. And in this, if you look at any arrangement, any system, you look at a charitable hospital, you look at a public-private arrangement, you look at a health insurance scheme, you can apply the lens of publicness. It's not only limited to public hospitals. Is it universal? Is it equitable? Is there free access? Is it comprehensive? Is it inclusive? Is there accountability? Is there solidarity and participation? ये criteria है publicness के. So this is a big topic, but I think I'd like to appeal to you कि advancing publicness can be the guide to move the health sector towards health for all in the 21st century, where all these different aspects of publicness, it's not just public ownership. Public ownership is part of the deal. There can be institutions which are not publicly owned but still operate with a public spirit, like some certain charitable hospitals, like certain other arrangements. This is, so finally, Rajasthan Right to Health Act. You all know what is going on. So one state government has had the courage to bring in at least some kind of act to assure at least public health services to people as a right. अभी उसमें एक्ट में कुछ कमियां हैं, उस एक्ट में कुछ ग्रे एरियाज हैं, उसमें कुछ एम्बिग्युइटीज हैं जिनको करेक्ट करने की जरूरत है, जिसको मॉडिफाई करने की जरूरत है. लेकिन कम से कम उन्होंने इंटेंट तो दिखाया कि पब्लिक हेल्थ सिस्टम में आप जाएंगे तो पीएचसी से लेकर के और मेडिकल कॉलेज हॉस्पिटल तक आपको एश्योर्ड राइट के रूप में कुछ हेल्थ केयर मिलेगी. वी हैव एज जन स्वास्थ्य अभियान वी हैव वेलकम द एक्ट while suggesting certain modifications, and unless the state government increases its health budget, expands its public health services, it's not going to work as it's intended. So many other things need to be done, and it's actually a right to health care act. It's not a right to health act. उसमें सिर्फ केयर है, उसमें हेल्थ के बारे में बाकी कुछ नहीं है. बट ठीक है, हमने कहा चलो आज हिंदुस्तान की आज जो हालत है इसमें एक राज्य में कम से कम एक तो कदम उठाए. As you know, the doctors have called off their protest, but earlier they were completely rejecting the bill. Now, because private hospitals which have not received public subsidies are more or less out of the emergency care provision. And so anyway, these are some of the modifications that and the measures that we had suggested. So now moving beyond COVID, we need a new vision of public health. जब आप किसी लंबी बीमारी में से निकलते हैं तो निकलने के बाद में आप वैसे ही नहीं रहते जैसे बीमारी के पहले थे. कुछ तो नया आप कुछ नया सीखते भी हैं और आप कुछ नया अनुभव भी करते हैं. तो इस कोविड की जो लंबी बीमारी से निकलने के बाद में हमारा हेल्थ सिस्टम में कुछ तो बदलना चाहिए. तो क्या बदल सकता है? हाउ कैन वी कन्वर्ट द टफ लेसन्स ऑफ कोविड इनटू बिल्डिंग ब्लॉक्स फॉर हेल्थ सिस्टम चेंज? रीइन्वेंटिंग सोशल सॉलिडारिटी, दैट इज द बेस. ये हम दिन रात यही काम करने की कोशिश कर रहे हैं. जहां जहां लोगों के साथ हम बात करते हैं, गांव में, शहरी बस्तियों में, भाई एक साथ आओ, अपने स्वास्थ्य के लिए मिलके कुछ करो. आप खुद नहीं करोगे तो सिर्फ सरकार नहीं करेगी, प्राइवेट हॉस्पिटल तो बिल्कुल ही नहीं करेंगे. आपको खुद एक साथ आना पड़ेगा. एंड देयर आर नाउ दैट बेस हैज बीन क्रिएटेड, रिकॉग्नाइजिंग द इंडिस्पेंसिबल रोल ऑफ फ्रंटलाइन वर्कर्स. वो बेचारी आशा, उसको क्या मिलता है और वो क्या काम करती है, इसके बारे में कभी सोचिएगा, कभी जाके उससे बात करिएगा और आपको समझ में आ गया कितना इंपॉर्टेंट है. एक्सपेंडिंग द नोशन ऑफ पब्लिक. पब्लिक मतलब सिर्फ सरकार नहीं होता. पब्लिक इज नॉट जस्ट द गवर्नमेंट. Public includes panchayat members, public includes volunteers, public includes civil society organizations, women's groups. They showed during COVID that they can be part of the public health effort. Do you want to let go of them? Do you want to forget about them, or do you want to bring them on board as part of the public health effort? I think that is a crux. Public को expand करेंगे तो public health system जरूर strengthen होगी. Public को भूल जाएंगे तो बेचारे पब्लिक हेल्थ सिस्टम जैसी है वैसे ही लड़खड़ाती हुई चलती रहेगी. सो वी नीड टू डू, बट दैट हैज टू बी डन विद अ बेस ऑफ इक्विटी. Developing right to healthcare as an accountability framework for social actors and an enabler for health systems. So we need to engage with the concept of right to health and right to healthcare. I think already the stage has been set for that. Rolling back privatization. Privatization failed during COVID. Privatization as a policy failed. It did not help people. Of course, the private sector did give services. The private sector did treat many people. But in the first wave, in the beginning of the first wave, so many private hospitals closed their shutters or they said, we are not going to treat COVID patients. That is an example of what the private sector's, market failure. So we need to continue to engage with the private sector, but have a different kind of, approach to it. And mobilization of medical victims is something which we have already described. We need to look at the private healthcare sector in a differentiated way. जो छोटा इंडिविजुअल क्लिनिक वाला डॉक्टर है, जिसका छोटा हॉस्पिटल है, जो अभी कमर्शियलाइज उतना नहीं हुआ है, उनको हमको पब्लिक अम्ब्रेला के नीचे लाना चाहिए. They should become like the NHS, which brought all the individual practitioners in UK under the public system. Till today, the NHS doctors, they have a contract, So we should welcome 80% of our individual doctors, small hospitals into a UHC system. भैया आ जाओ आप लोग, आपको ठीक ठाक पैसा मिलेगा, decent income मिलेगी, profiteering नहीं होगा. डिसेंट इनकम मिलेगी, प्रॉफिटियरिंग नहीं होगा. अगर ये मंत्रा लेके हम चलते हैं तो 80% प्राइवेट सेक्टर हमारे साथ आ सकता है. अब बड़े जो अपोलो और आई डोंट वांट टू टेक नेम्स, बट उनको ये हजम नहीं होगा, उनके लिए ये काफी नहीं है. हमको बोलेंगे भैया दाल रोटी सब्जी चावल मिलेगा, लेकिन वो बिरयानी तो शायद नहीं मिल पाएगी. तो जो आने वाले हैं वो आ सकते हैं. दैट इज हाउ वी नीड टू स्टार्ट टेकिंग स्टेप्स फॉर एडवांसिंग पब्लिकनेस, regulating commercialization on the path of universal healthcare and health for all. So this is my final slide. This is what we saw before COVID. Profit logic has been dominant, and that is pushing commercialization even during COVID, even beyond COVID. And the social logic, which is the public health system, but not just the public health system, many other public actors also, this has been the smaller पहलवान. मुझसे जब लोग पूछते हैं भाई क्या होना चाहिए अपने हेल्थ सिस्टम में, मैं एक सेंटेंस में उसका जवाब देता हूं. ये छोटा पहलवान है ना, ये बड़ा होना चाहिए, और जो बड़ा पहलवान है ना, वो छोटा हो जाना चाहिए. बस सिंपल. वो बड़ा पहलवान रहने वाला है, प्राइवेट सेक्टर रहने वाला है, उसको वी कैन नॉट विश इट अवे, लेकिन भैया उसको रेगुलेट करो. उसकी भी कुछ सोशल अकाउंटेबिलिटी है, और जो सोशल लॉजिक है ना, उसको मजबूत करेंगे तो इस देश के हर नागरिक को, रहने वाले हर व्यक्ति को हेल्थ केयर राइट के रूप में मिल सकती है. वी नीड टू रिकंस्ट्रक्ट a public centered UHC system which will give good quality health services to each and every person in this country as a right. Let us not revert to privatization. Let us take forward health for all. Thank you.
Thank you so much, sir, for a very passionate and stirring talk as always. So, unfortunately, the right to health movement, when it was being rolled out in Rajasthan, so most of us would imagine the doctors would stand for the public and then towards the side of right to health. But they came out in hordes against this right to health. So that is what the market economy has done us to us doctors and public health practitioners, that we are now forced to stand for. I'll take the questions later, sir. So before can we have the lights now? So we can, before we move on to address by Professor Amarnath and then by Dr. Chandrakant Panda, we can have 3 or 4 questions from the speakers. So I'll request the audience to, if they have any questions, comments, keep the questions brief, please. Stand up, introduce yourself, and then identify the speaker you want the question to be answered by.
Okay. I'm Dr. Ashwini. I am second year postgraduate student at VMMC and Safdarjung Hospital. It was a very enlightening talk by you, sir, Dr. Abhay. Sir, I have 3 questions from you. I'll try to keep it.
One question per person. If there are no more questions, then we can come back to you.
Sorry, sir? Okay, sir. ठीक है sir. Sir, find the one that I will ask that I think could be of my interest is, so every time we go for any disease or any program, anything, we start talking about the stakeholders of that particular problem. And also we talk about the multidisciplinary approach that a holistic health practitioner should understand, especially we people as community medicine people should understand. So for my fellow MD students in other branches who are also working in the public sector, NCDs, infectious diseases, others, they are doctors in the public sector, so they themselves do not understand public health. And it is also coming from a very recent experience. I was posted in pediatrics, and one of the consultant had a question as to where else can a very small thing as immunization can occur. So he's such a senior person working for 20 odd years in the public sector, and just because they are confined to the hospital is because they do not understand the public system, which effectively they are under.
Ask you a question. What is the specific question?
So the question was that, sir, we focus too much on the UG training curriculum as far as community medicine goes, and as Srinivasan sir had mentioned that the exposure is not enough. So what about the people who are in all branches in the MD? So sir, if we can give them some kind of exposure to their respective commodities like OG, pediatrics, NCDs, then I think, sir, they will understand the public health system way better, like the way we do.
Thank you. You have given the answer yourself. You still want a clarification from
I
sir?
said,
Please.
so my
Sir,
question now is, sir, that is this feasible? Like,
Okay. So that's the operative part. So is it visible, sir? Please. Acha. More questions.
I have two more questions. Okay.
Will come later. Your name, please.
My name is Sanjeev.
ये जो माइक है ना ये बैठ
हाँ बैठ के ही करना है बैठ के करना हाँ please sit down and then
I can speak. Mic. Use mic.
sit down.
Yes, sir. Sir, my name is Sanjeev. I am PG resident, second year from Sabdarjung Hospital. So my question is, what we are talking about the quality of care in the government sub-centers and public health centers, and who is the authority to check this and the implementation of the regulations in the public health sector?
Okay, thank you. Any more questions? Adish, Ashwini, and
Good afternoon, sir. I am Dr. Major Abhishek Sharma. Sir, after your area of responsibility in Maharashtra, what you told, I was posted in Nasik Devlali. Sir, little small question. There were few villages known as Dudgaon, Basali, Ambad, Talegaon, which were at a fair distance of around 40 to 200 kilometers away from Devlali. Sir, there was basic medicine like a paracetamol they could not get at their respective places. And the poor man had to come from there to Devlali for 40 rupees, incurring more cost in traveling. And all of this was covered by the government saying that COVID is going on, we cannot give any other care. And one last point, sir, there was one more question, that many deaths that happened sadly were blamed under the blanket sanction of COVID. Many deaths that happened otherwise, just to mint money as you portrayed in your slides, sir, money was siphoned off from the general public. He would have been having a heart attack or a MI for that matter, and he was put under a COVID. And the body was not released, sir.
okay, thank you. The point taken. Ashwini, you can come up to the mic and then.
Hello everyone. My question is to everyone here, especially very respectable Chandrakant Pandya sir also, that we can see every year with PARC and in government guideline also that the number of PHC and CHCs are decreasing in spite of course, the population growth and all. So what we all can do together to decrease those to prevent the decrease in number of CHC and PHC, and what we can do to increase those numbers in the rural settings, which is much needed.
Thank you.
Sir, I think numbers are enough, but the quality of care is very less as compared to.
Yeah.
Sir,
Let's not have a cross talk, please.
If you go.
Adish, please.
Good morning all. I'm Atish, junior resident at Center for Community Medicine. My question relates to the right to health or rights-based approach to health. So already, if we look at nutrition, National Food Security Act is there. Now we are talking of right to health, or as sir said, right to health care. So how long before we can expect the right to preventive and promotive services in addition to the curative? So right to have an ASHA visit, right to be vaccinated in the sub-center. So how long before we can expect that? Thank you.
Okay, thank you, sir. Sir, over to you, please.
Yeah. So, yeah, first of all, very good that you asked all these questions, and probably we could have much more discussion if time had permitted. So, all branches of PG should have orientation on public health. Public health is, I mean, as you all know, is not just about working in a public hospital. Because you work in a public hospital, that does not make you a person acquainted with public health. What you're talking about is you're a gynecologist or a surgeon or something, you're working in a public hospital like maybe Safdarjung or some other place. So, but you're working just as a clinician. So the understanding of clinicians, let us say, also needs to be expanded to include an angle of public health. If I'm a gynecologist, I should be concerned about the nutrition, the anemia of the mother in those 9 months before she comes to me for the delivery, about her, and various other aspects, immunization and antenatal care, etc., etc. So today that is not happening very adequately because we have a lot of compartmentalization in the entire medical education system. So public health wale sirf public health ka hi dekhenge. Public health people also should have a good clinical sense. I mean, not that they will become clinicians, but they should, have a familiarity with clinical issues, because you need to know कि इस patient को कहाँ जाना चाहिए, इसका क्या होना चाहिए, etc. And similarly, clinicians should have a basic orientation about public health. So I think that is a very valid observation. Is it possible? In some other countries in the world, it does happen.
Can I make it?
Yeah.
Just hold on. Let them answer first, then we can. We are running short of time, sorry, Mother. So we have to wrap up.
Make one comment. From now on, it will be known as Shukla Bevan principle. Very good talk, very good thing. But let me just put it in perspective. Britain has a GDP of 9%. Europe has got about the same, 9% of GDP is spent on healthcare. And how much is USA spending? 18%. Now, 18% means 9% is from the government and 9% is private. So we cannot underestimate the contribution of private healthcare either, number one. Number two, we are confusing the issue here. Public-private is different to tertiary and primary. I think this is the big difference, that primary care can be private. Now, I've seen people from the big hospitals going into primary care now. They're setting up small, urgent care centers. So that is like a primary care. There people can walk in for a small fee and have immunization. And so that is primary care. Minor illnesses, immunizations, child health, antenatal checkups at a primary care level. That can happen both in private and in public health. So I think we are confusing here, that we are thinking public health is entire responsibility of the government.
Okay, point taken, sir. Dr. Sanjeev, sir, you would like to add, clarify any of the
Very
queries?
important question, and as I always say, no session has solved all the problems of health in India. So what we are telling you is our perspective, you are telling your person, so you will not get a final answer. You walk out of this room and health for all is done for everyone. So keep that in mind, otherwise we will all get Nobel Prize if we do that. One is orientation. Nobody goes for post-graduation without MBBS. We have to make sure that our teaching in MBBS is family oriented and we understand what is health. When we were students, PSM department used to take us on a fixed day to we used to go to Malviya Nagar, sir. We were allotted families, 5 families each were given to us. We used to take care of the family members, health issues, and we had Malviya Nagar Hospital attached to AIIMS, and we used to bring them to Malviya Nagar Hospital for basic investigation. If required, bring them to AIIMS for investigation. So start with undergraduate, and AIIMS Jodhpur is currently working on developing an MPH, I won't say MPH, public health course for all clinical residents. So that aspect is needs to be looked into. Starts in MBBS, solid footing in MBBS, because the students are there for a longer time, and as AIIMS Delhi used to do, I don't know if other medical colleges are doing that. You understand the implication. Second is resilience of health system. You can't close the whole country. You know, people who are daily wages laborers, they will die of hunger because they get money every. Similarly, you can't close the hospital when an epidemic comes. Will people stop delivering babies? Will they stop having heart attacks? What about those who are on cancer treatment, need chemotherapy, radiotherapy? Their treatment will stop. Cancer will stop spreading. This is a very short-sighted view of looking at only one problem at a time. As a public health person, we need to look
Thank
at
you so much, sir.
holistic-
Apologies.
Number of PHCs. Giving numbers is one step. But what about people coming to these facilities? The number of people coming to health facilities is going down. I was carefully looking at the data of doctors in private hospital getting COVID vaccine and doctors in
Government.
public hospital. The public hospital doctors' percentage of vaccination for COVID was less than the private hospital. Do we who work in public system have faith in our own system, of which we are part of it? Needs a deeper insight. Right to health is judiciable. If I don't get a service, I can go to the court of law. That is why private sector became shaky. Because if they don't provide services, people will go to the court, and the private sector service provider will get penalized, many of them fined and put in jail. That is what changes the right to health. It is judiciable. Health for all, UHC, you keep talking, but if I don't get services, where do I go? If it is right to health, court of law. is
Thank you,
open
sir.
to me.
Thank you so much. Now, we have another lecture scheduled here shortly. So before that, we want to hear from Professor Ellen Nath, sir.
The other questions, maybe we can meet
We can
after.
discuss over tea. There will be high tea after that.
Yeah.
So we are honored and privileged to have Professor Ellen Nath here with us today. I'll not make an attempt to even introduce her to this audience. So most of us know her very well, and even if I speak for 10 minutes, I'll not be able to cover even part of what sir has done over his lifetime. So sir, with these words, I was former Dean and Director of AIIMS. With this is only, I think, I'll say about sir. So please, over to you, sir. Your words of wisdom for us all on health for all.
Thank you very much. I'm in bit of a quandary. I don't know what to. I had made myself blissfully ignorant of what is going on, because I found that I could not contribute to that. I couldn't contribute morally to the decisions that were being taken, and I didn't have the ability to change the thinking. So I opted out. It's a coward's way. But unfortunately, coming and listening to you people has made me think again. How would I tackle this? What would my role be if I suppose I wanted to have a role? And I don't know what to say. I'm lost. I've been saying these things in front of all of you people. It's difficult enough. I mean, the next person to hear is one of my prime health providers, because he has access to the health care I need, and he arranges it. So for me, this is important. But there comes a time when you have to put your foot down and say, I won't be a part of that. I don't know the solutions. I don't know what to say. I'm lost. I can recall what happened in one instance or the other. I can recall, but my system of working is not without pain, because I think of all these people sitting here, all public health people, I have been charge sheeted by the government for public health. I got an official charge sheet because my intervention resulted in someone important in the ministry not getting his cut. At a time, I would laugh about it. And now I seem to think about it and say, you know, what do we do? What do I do? I remember, for example, Pandav said something about telling him that he would be, if he didn't do a thesis, it would take long. I didn't actually say that. What I said was, I will not sign a thesis which does not have, sign the papers for a person, student, who does not do a thesis. Now there's a difference there. But that's what I stuck my neck out. In those days I didn't care. I stuck my neck out and said, no, I don't care if this institute's academic body has said that thesis is not necessary for postgraduate students. This was a decision taken by the academic committee of this institution. And I said, I don't believe that. I don't agree with you. It is morally repugnant to me. And therefore, I had the dubious benefit of being the head of the department for too many years.
18 years, 78 to 1996.
But what was my objective? I could say to that fellow, I am not saying you don't do your MD. I'm not saying that you won't, this thing. I'm just saying that I will not sign your papers, saying that I certify this. And that was the...
Without signing papers, I cannot appear for MD.
No, he can. Other people can. In our department, if you recall, we had a lot of faculty. And the faculty all had equal rights to this. It's not that the head of the department could do anything. No. I'll give you one other example. And at this point, I can give names also. If another of his colleagues came to me and said, sir, I have decided on my thesis, this is the topic, and this is what I want to do. I had said to the department that you choose there's a whole lot of people who are qualified, you choose your guide, you work with them. I don't have to be everyone's guide. I don't have any right. I don't even like the idea of signing research papers just because I'm the head of the department. No, I won't do it. I will sign anything that I'm a part of, anything that I'm committed. But I cannot tell Mr. X that unless you make me your boss, you won't get that extra signature that may make your thesis publishable, which is a terrible system. Now, I gave you one example. people have been talking names, so I will also be fairly open about this. There was a lady, postgraduate student, who enjoyed life. She liked to live it up. She liked to work hard. She came to me and said that this is the, and I had, as they might bear me out, I had said to the postgraduates, choose who you want to work with. Don't come to me. Choose whoever you want to work. You want to work with me? Fine, I'm honored. You want to work with Mr. X or Mrs. X? Go ahead. Welcome. You choose, and you choose this depending upon your knowledge of the person who you want to work with. Now, her thesis, I would never have, under normal circumstances, accepted that as a thesis topic. But I didn't want to say that because I had the unfortunate position of being younger than much of the department, much than many of the faculty. And I was seen, therefore, as a natural obstacle to their progress in academia. You can't blame them for thinking that way. This lady wanted to find out something from a village. So I said, all right, do you mind if we try an experiment also at the same time? And the experiment was very simple. I said, have you got your questionnaire? Give me a copy of your questionnaire. I will fill it to the best of my knowledge. I will seal it, we'll put it in the safe. It will not be available to anyone. In due course of time, she came and said, sir, I have finished my thesis and it's accepted. And so I said, yeah. And then I remembered, or she remembered, that we had actually tried an experiment when she came to me the first time. And I said, let's compare those papers. Let's see. You acquired some knowledge by going to the field. I am using my accumulated knowledge. I called Eldosa secretary. I said, I'd given you an envelope sealed and countersigned by one of our students. He said, yes, sir. It's there, intact. No. Bring it. Give it to her to open it. She opened it, she read it, and she burst into tears. God. One of the worst things that can happen to you is some student in your room starts crying. I said, what's the matter? What's wrong with you? He said, no, but you didn't tell me that don't do this study. It is because you have actually had by chance, some chance, 100% coincidence with her answers in the questionnaire that I filled before she went out into the field. I said, now why are you crying? He says, but you could have stopped me wasting, I could have done some useful work. I said, no. Your purpose was to learn techniques, not to make original research. You have done that, and you should think. He said, no, you're just doing that to soothe my fear. I said, no. If you think that you're going to do, in your first thesis, you're going to do Nobel Prize type research, forget it. That's not what your purpose is, not original research. Your purpose is to learn how to do research. And that's the difference between an MD that we conceived and other people had. Anyway, she accepted that finally. And incidentally, she became very high up in UNICEF. It's very clear.
Yes.
Huh? You know,
Monica Sharma.
Monica Sharma. Yeah. So this is a type of situation that one faces. But I get a charge sheet because I advocated the bifurcate needle instead of this massive compressor that the World Bank, that
Smallpox.
for smallpox. There were people buying one, going to be buying one compressor, enough for the whole, one compressor for each group of people that, and in that whole very expensive large compressors, in the thousand. And we could buy the price of one of those things could buy bifurcate needles for the rest of the world also and for them also. I put it that way. And I got a charge sheet from the ministry saying, who allowed you to do this research? I had just joined. I said, I thought my job was to do research and teach students how to do research. And I don't need to teach it necessarily in theory. In theory, I can sit together with them and plan and do a project and see the advantage, disadvantage of various methodologies. We took 9 volunteers from the nursing college and we tried different methods of immunization for smallpox. And the most trauma-free, scar-minimizing methodology was the bifurcate needle. Unfortunately, then I told them that unless a study is published, it's not research is not should not be considered completed. So we published it. We published it. The people in the US saw it and said we can't supply these things to them. They've got a better method. Now, I don't know.
And several times, sir, sir was responsible for many policy changes in this world, at least in this country. Even during COVID time, several times he called me. Sir, बहुत ही कम फोन करते हैं कि संजय, मैंने तुम्हारा इंटरव्यू देखा, really, I like the way you are expressing yourself without any fear. So this is the public health. So several times sir ने phone किया, क्यों sir? So
Thank you so much, sir. Just to add anecdote, Dr. Sanjay also आज भी वो पुड़िया बनाते हैं जो आपने अभी बताया ना कि envelope seal किया. Just remember, for various contentious issues, we have a discussion. Mohan is also there. So certain issues we put something and then seal it. Key will open it after 6 months and 1 year. So that tradition is still continuing in CCM, sir. So with this, thank you so much, sir, for your inspiration and words. Now we come to the end of the event and request Professor Chandrakant S. Pandav, who is the IAPSM of India and who is chairing today's session, to give his closing comment. Sir, we are already overshooted into your session. You are also scheduled to speak next for 1 hour. So with this, over to you, sir.
I just want to say that before requesting Dr. Nath to come here, I was barbecued by him for 5 hours. Grilled for 5 hours at home. He asked me the same question, what shall I say? He is a man of brevity. Whatever he says, you need to go into thinking mode. So as a chairperson, Anup, welcome, Anup Sarai is there. He has written a very exciting book on health beyond medicine and one on food security. तो आपका स्वागत है अनूप. So I just want to say that this should not be one event. There are how many medical colleges in Delhi? 6, 7, 8 पता नहीं कितने.
NCR में 19 है सर.
20 है.
19 अगर NCR ले लो तो पूरा 19.
So by rotation you should have one monthly meeting like this. So I always think of the future. By rotation आप कर लीजिएगा. Don't be one of events. Finally, I want to say a short thank you and a long thank you. Thank you and thank you very much.
Thank you so much, sir. I'll request Dr. Mohan Barwa to give a very, very brief vote of thanks. Then we can after that break for the high tea. Thank you so much.
Dignitaries, friends, guests and friends, as always, we have reached towards the conclusion of the meeting. So I am humbled and honored to propose vote of thanks for this meeting. So on behalf of Delhi chapter of IAPSM, Delhi chapter of IPHA, Center for Community Medicine, IPHA AIIMS branch, and NCEAR-A. So for this meeting on 75 years of improving public health in India, we have discussed a lot and we have got significant insights on health for all and right to health. So I express my heartfelt thanks and gratitude to Professor Srinivas, Director of All India Institute of Medical Sciences, for joining us today for inauguration of this meeting and his constant support and encouragement for the Center for Community Medicine and this event. I also thank my gratitude and warm regards to Dr. Sanjeev Kumar and Dr. Abhay Shukla for sharing thoughts on this today event on health for all and getting us through the memory lane of health system evolution in India and through COVID-19 and the challenges ahead that we need to address. I also extend my thanks to Dr. Professor Alam Nath, former director of the AIIMS New Delhi, for gracing the occasion and sharing his wisdom and kind words for health for all and this event. And I also thankful to Professor Chandrakant S. Pandav, former head CCM AIIMS New Delhi, and who has been a constant source of motivation and encouragement for us to work for the welfare of the people. I wish to thank Professor Jugal Kishore from Safdarjung Hospital and MMMC, and he is also president of IAPSM Delhi chapter. He supported the events and he has shared his kind words with us. I'm also thankful to Dr. Amol Dogre. He is from Department of Community Medicine at Maulana Azad Medical College and representative of IPHA Delhi chapter. He has supported this event and joining us today. I wish to thank all the guests, colleagues and friends whose name I may have missed and who participated in this meeting and contributed to its success. I sincerely thank Professor Sanjay Rai, President IPHA, and all faculty colleagues for supporting this endeavor. And I wish to thank Dr. Kapil for entrusting me for proposing vote of thanks for this event. Finally, I am thankful to residents of Center for Community Medicine and research staff, those who have contributed to making this event successful. With this, I give rest to my words. Thank you so much.
One last